You count down, so Mr. Sunil, Mr. Sunil, check the time also.
Will do, ma'am.
It will be okay. All the videos are 4 minutes.
Live.
A very good afternoon to one and all of you. On behalf of ARC, we welcome you to another very informative webinar, which is going to be packed with lots of science, those extra clues which you pick up in these webinars to keep us all going. You're truly lucky to have an amazing panel led by our President, Dr. Mahipal Sachdev, the President AIOS, an individual who has actually taken the bull by the horns during this pandemic times. We have with us our ambitious, focused Honorary Secretary, Dr. Namrata Sharma, who's yet to join us. We have with us our past President, Dr. Ramurthy, Chairman, the I Foundation Group of Hospitals, who would definitely help us garner more knowledge in science at all times. We have with us Dr. Debashish Bhattacharya, who is yet to join us, past President and Founder Chairman of the Disha Eye Hospitals, who's going to add more wisdom to the moment. Dr. Mohan Rajan, welcome. Chairman and Medical Director of the ever-famous Rajan Eye Care Group of Hospitals, Chennai, to add to the wit, humor, and science in this webinar. And finally, Dr. Rohit Om Prakash, heading the Dr. Om Prakash Eye Institute from Amritsar, who's going to teach us a novel approach. Dr. Anaga Harod, who's the member ARC and Medical Director of the Anil Eye Hospitals, would be co-moderating with me. So before we start our session, just let's have the presentation of Entor, Mr. Sunil, for a minute. Thank you, Entor. We shall start our session now. And as two of our speakers, one, Dr. Ramesh Dore Rajan, who was father keeping very unwell, has could not join, and of course, Dr. Ellen Kumaran. So I think we could take more of discussions. So please, all of you, be geared up. We're going to drill you. Let's start this awesome 2.5-hour session with Dr. Amit Porwal, who's a member scientific committee, senior consultant and head of the glaucoma department at Chaitra Netralia, Indore, a surgeon of great repute, who's going to show his piece of wisdom. On to you, Dr. Amit. You could share.
Thank you, Dr. Chitra and team ARC for inviting me for this great webinar on cataract surgery. I'm going to show you in this 4 minutes a video on a posterior polar cataract. And how an uneventful surgery became an eventful surgery and how well it was managed, what were the mistakes which I did and which should not be done in the future. So waiting for the inputs from the extreme panelists, and now I start my video. So this is a case of posterior polar cataract, wherein as my routine procedure, I do a temporal phaco. I had marked the 3 o'clock and 9 o'clock position because was implanting an in-focus trifocal IOL of Upper Swami. So the two side ports were done with an MVR, and under the air bubble, the entry capsule was stained with trypan blue dye, and sodium hyaluronate was injected before starting the rexis. So now after injecting sodium hyaluronate, I make my 2.8 mm clear corneal incision. So after that, to get a perfect circular central rexis, I mark the rexis with the help of a rexis marker on the cornea. The tip to do this is you should have a dry cornea before you mark with the rexis marker. Never moisten the cornea when you use the rexis marker. The advantage of this rexis marker is, especially when you're using these premium IOLs, it gives you a rough estimate that your rexis is central circular and is not getting decentered. And it will always gives you a guide if you're going away from the center. So I marked the rexis marker and I proceeded with my capsular rexis. A perfect capsular rexis was achieved. Always follow all the trips of capsular rexis which you have been learned and which have been taught by your seniors and your mentors. So I follow that, and now a partial hydrodissection is done. What I do in PPC is I use partial aliquots of hydrodissection and do hydrodelineation. So multiple hydrodelineation is done at multiple sites so that you get the golden rings at various places or various golden rings. And once it is done, then I try to rotate only the central nucleus. The dictum in PPC is never rotate the nucleus, but if you have done a hydrodelineation, the central nucleus is there that you can dislodge it. So the preferred technique is top and chop, but since this was a very soft, there was no nucleus at all, I just aspirated the central nucleus under the very low settings. And whenever we are doing a PPC case, I always use a low power setting. That is, the bottom right should be low, the power should be low, and the vacuum should be low. So once the central nucleus is aspirated, in the epinucleus mode, I'm trying to peel off the epinucleus and the remaining cortex from all 360-degree with the help of a phaco probe. And you can see whenever we are going to withdraw the phaco probe, we should always maintain the entry chamber by injecting the viscoelastic to the side port. So now, after I did, the subincisional cortex or the epinucleus was there, which I'm trying to dislodge it. But you make sure when you're dislodging it, you don't dislodge the central PPC core. You just try to dislodge the peripheral epinucleus. You should not dislodge the central epinucleus core. So I did that. And after dislodging the peripheral epinucleus, I'm trying to aspirate it. And you can see that when I'm aspirating, the PPC also gets aspirated. So if we go at the grading of the posterior polar cataract, basically there are 3 grades, grade 1, grade 2, and grade 3. That is the OCT based grading of the PPC. And this was grade 2, even though I don't have an intraoperative OCT. But you can see that the PPC component came out. The PC is intact. It is very thin. PPC is intact. So it's a grade 2, type 2 PPC on the OCT classification. So you can see it's a closed chamber technique. All the cortex which was there is being aspirated with the help of a biomineral technique. The central posterior capsule behind the PPC is still intact. But you see, when I withdrew my irrigation aspiration port, I didn't maintain the anterior chamber by injecting the viscoelastic. In a haste, I just withdrew it, and you can see that whatever thinned out PC was there, it started giving away. So the instrument touch was not there. Patient was lying down. I took out my irrigation aspiration port. There was sudden decompression, and the posterior capsule gave way. So this is very common in PPC because the posterior capsule is so thin. If you don't form the anterior chamber by injecting viscoelastic before withdrawing your instruments, there are chances that this type of situation can arise. So again, this rent had occurred, and this patient was very uncooperative. This was a young female, 37 years old. So she was very uncooperative. So I thought of using visco and aspirate the dry aspiration of the cortex, and then automated vitrectomy was done. You can see that the PCR, whatever had occurred, is maintained. It has not enlarged beyond that. I'm doing an automated vitrectomy. So when you're doing the automated vitrectomy, you have to be careful that there's no vitreous strand. And the same InFocus IOL, which was planned, is implanted into the capsular bag. You can see the central ring of the InFocus IOL, the central button of the InFocus IOL. Now, after injecting the IOL, the visco is washed, and you can see throughout that the pupil is well dilated. There's no surge at all when we are doing the case. I've injected pilocarpine to see whether the IOL is centered properly or not. And you can see that the IOL is centered properly. The pupillary opening is nicely centered. And this is the way this case was managed. So the only advice what I would give through this case is that never allow sudden decompression when you're doing a PPC case, even though we don't have a PCR, even though if you have an intact capsule, never give sudden decompression, never withdraw your instrument suddenly, always maintain the entry chamber by injecting viscoelastic through your side. Thank you, and waiting for input from the esteemed panelists and the moderators.
Thank you, Dr. Amit. That was
Very
a
nice.
video so clearly explained. So let me get to you. I think I don't know whether everybody noticed, the first wave was a hydro dissection wave which moved through, which was there, but it may not have been the cause of the PCR which occurred. And definitely those multiple hydro dissection delineations create those multiple layers of cushion which protects the posterior capsule. But when we saw that PCR, I noticed that you've enlarged your side ports to introduce the Simcoe. I feel you could have used those PC polishing mode itself and remove the remaining cortex, because it makes sense to have snug fit side ports with the vitreous not getting too hydrated and going and removing that cortex, and the PCR would not have enlarged because it was a circumscribed one. So your thoughts, Dr. Mahipal, you have anything to add?
The reason to enlarge the side port, Dr. Chitra, was that
I want Mahipal to
yeah.
Okay, so Dr. Amit, you have very nicely highlighted what all is supposed to be done as regards the posterior polar cataract. A couple of advices that I'll give is that we do have the anterior segment OCT, etc. that's available. Even the IOL Master 700 can give you. So it's always advisable whenever you see a posterior polar cataract for all those who have a device in the form of a anterior attachment of an OCT and the IOL Master 700, they can get an image. The second thing is also a good slit lamp examination will also will show whether there is a pre-existing rent or not, and you need to be extra careful. In case you are going towards suspicious cases, I would always prefer to do them under a block, because what you said was that there are patients who the patient was non-cooperative or uncooperative, so that situation can be avoided, and it's always better to do it under a block. Apart from that, I think the way you managed with the hydro delineation and not a dissection and also not a rotation are the important things that have to be done. Your tip of having a posterior capsular rent, even though there isn't a rent, but there is a weakness. So often these posterior polar cataracts are associated with weaknesses at that place, which are not actually a rent at that time. And a sudden upthrust can give that into a rent. I would have always kept a 3-piece as a standby. You can make that into posterior capsular access if that is there. I would also think of possibly implanting a IOL before, because there was a little amount of cortex that was left, and you could, with a scaffold of the IOL keeping the vitreous back, you could kind of remove the cortex later on. And obviously, we have publications. Dr. Namrata has also joined in and others have also experienced that if you have a flax system, you can easily identify whether there is a pre-existing rent or not. And there is 100% of the cases we have been able to identify if this will have a rent or it will not have a rent. But overall, I think your tips that you have given, and also one thing, bimanual aspiration in such situations with lowering the bottle height and the parameters is also something very, very important. And as you were trying to do, maybe we could have removed the top part and then gone towards pulling out the central PPC. You should do that towards the last. So even if you strip the epinucleus or the cortex, just try to preserve the central part, strip it to the mid periphery rather than stripping it to the center, because once you peel off the center, that is when the rent would come. So overall, I think you managed it very well. Good tips, and whatever additional I wanted to add, I just have added.
About
Thank you.
the use of enlarging the incision and use of Simcoe, like I wanted the answer for that.
Actually, the biomanual dropped out when I was doing the biomanual.
You can do a dry aspiration. That is the advantage of a Simcoe, but I don't know where our Simcoes are because we hardly use them. But lowering the bottle height, putting viscoelastic into the chamber and using an aspiration as a side port is going to be as effective as a Simcoe. Simcoe, I think the way with a bimanual, you will get a good thing. There's no harm in using a Simcoe. I don't personally use it, but there's absolutely no harm. That's called dry aspiration, which we typically used to do when we used to have rents. I think that's your question, or you had anything else?
Enlarging the incision.
Yeah, Chitra wants.
Incision 3, a new,
Can I add something, Chitra?
new incision, because you will have to have, you shouldn't struggle at that particular time to insert the Simcoe cannula. I think that's the reason why.
The biomanual is 20 gauge and Simcoe is not 20 gauge. Simcoe is 24 gauge. So we have to enlarge the incision.
That is why you need to be snug fit side ports. So why do that? You could have continued with what.
That's what I told, that the biomanual, because the patient was uncooperative, my assistant started panicking. So she dropped the biomanual. So now there is no biomanual, and instead of waiting to get another set from the CHSD, I thought Simcoe is always there at the standby in all our sets. So let me continue with the Simcoe itself. And the only thing which I wanted to stress was in spite of all this, the sudden decompression was the main reason for the PCR, and 3-piece IOL was there at the standby. But because the rent was not big and the bag was proper, so I implanted the in-focus lens itself, and the patient is having post-operatively very good vision. So the dictum, what most of us say, that if you have a rent and if you are implanting a multifocal or a trifocal IOL, you have to be very careful that it is properly centered. Otherwise, in the case of a rent, don't implant these premium IOLs. So this was the thing which I also wanted to highlight, other than the rent.
I think the IOL was perfectly centered, because you could see the Purkinje images right in the center, the 3 images of the filament right in the center, when the patient was looking up. So centration was good.
Yeah.
Yes.
Mohan.
Yeah,
Actually, let me compliment Amit for the wonderful video, but certain things I would have done differently. One is, this is not a pre-existing dehiscence of the PPC. Okay, the pre-existing dehiscence, you will see like 2 pillars on the posterior capsule. It's not like, it's probably because as an upthrust, the PC is weak, and because you're not injected viscoelastic, it is opened up. And obviously there is vitreous also there. There is an anterior hyaloid also ruptured and vitreous. You cannot use Simcoe, manual Simcoe for this, because there is vitreous already there. You can't just use Simcoe and aspirate in the presence of vitreous in the anterior chamber. So that's ruled out completely. Second thing is, when you have a PC tear, and you got away in this case, but putting a single piece lens in the bag without doing a posterior capsular Rex is a little dangerous. Because sometimes, most of the times what happens is, when you try to put the lens, the PC tear will start extending. But when you convert that into a posterior capsular Rex, Maipal said it very nicely, I think that is the best way to make sure that the posterior capsule is strong enough to hold the lens in the bag. So
this posterior capsular rent was like a PCC itself. It was nice circular opening.
Described PCR, so he could get away in those situations.
Yeah, probably you got a better. I would have converted that into a small posterior capsular Rexis, because I want the stronger edges there and make sure that otherwise I would have put a multi-piece lens and captured the lens in the capsular Rexis margin, and no rotation of the nucleus, no hydrodissection, and only hydrodelineation. Nowadays I'm doing flags for all PPC, even if the patient does not pay. I do the flags because for me personally, after seeing Maipal's paper and also experience over a period of time, personally I feel that flags, definitely the intraoperative control is much better than your manual phaco.
Is there any role for doing a primary capsular, posterior capsular Rexis with flags?
Why not?
In posterior polar cataract?
No, as of now you can't do that.
You
Obviously, you will have to have everything out, and then you have to put a suture and then do that. So that is still not.
Why it is not possible, sir? Is it because there is no license for that, or because
No, sir. No, we had to open we already opened the eye. No,
No, Mohan. They are trying it for doing a posterior capsular access even in children. So as of now, the software and the license is not available. So it has to be an FDA approved procedure. So still that is not available. But I think it is very much in the future it will be available, because even the femtolaser is now being used for retinal surgeries, for even epiretinal membranes and things like that, or cutting membranes. So that will sooner or later be available, but just now it's not available as a primary posterior capsular access.
Do you have any other question?
Yeah. Can I just make a comment, ma'am?
Yes.
Yeah, excellent case, Dr. Amit. One thing I wanted to ask you is, in these cases of PPC, where you probably expect a defect to occur on table, have you counseled the patient, because you're putting a premium multifocal IOL, that in case there is a problem, you would not do it, and how would you
Every
manage?
patient of PPC is counseled in
Yes.
3 terms. One is, I may not implant the same IOL which I have promised. Second is, you have to be ready for an extended hour of surgery. Third is, you have to be ready for a second surgery also later on. If in case due to anything I'm not able to inject the IOL in the same sitting, these 3 points are always stressed and written on the file also before we
Yes,
take this
exactly.
patient for
This is
surgery.
what I wanted. Right.
Ravi, regarding your question regarding usage of femtosecond for posterior capsular access, I think it is possible mechanically, but obviously you don't want to have an open posterior capsule with the lens matter inside. So that is the challenge. So obviously you can focus on the anterior capsule, then on the posterior capsule, especially if the lens is clear. But if you create a rexus, posterior rexus with the lens matter inside, obviously that will be quite a mess. So you have to remove everything and redock to create a posterior rexus. And regarding Amit, your case, I mean, excellent case, very well managed. And I think you brought out that pearl. I keep emphasizing this of using the capsular rexus marker. It's such a simple, elegant device, but I don't know why everybody doesn't use it. You have 5.5 millimeter mark, and you follow the inside of it. Every time you end up with a 5 millimeter rexus. I think that's something everyone should adapt. And as regards the other points, I feel that, this partial hydrodissection, I somehow just don't believe in. I think, I mean, it's you just don't have that kind of a control when you're manually doing it. So it's always a good idea to stick to just hydro delineation, though that was not the cause for your rent in this particular case. And I believe the best way to do it for the listeners is that you go into the substance of the nucleus, hit the hard nucleus, and there you give a gentle push, and you get the just the good hydrodelineation alone. And I think keeping the chamber well formed with the viscoelastic is extremely important. And if only it had been tightened up, maybe this complication would not have arisen. I can't agree more with Maipal and Mohan as regards the usage of 3-piece lenses in these cases. We actually have a +4 diopter 3-piece lenses always in stock in case a multifocal lens is promised and we end up with this kind of a situation. That's the lens which goes in. And finally, I think today we have reached a stage where any case where you have a vitreous loss, I think it's not right to leave the eye behind without doing injecting a little bit of diluted tricot and making sure that there's no vitreous in AC. Maybe you did that, but that was not missing. But I think that's even after everything is over, you can just through a tricot, you can inject a little bit and make sure there are no strands in the vitreous.
Actually, you could even do a visco dissection after that endonucleus is out, because the bag is no longer distended. So, and there's a great ease in removing the other cortex and everything without traumatizing the zonules, because sometimes it gets difficult to do because you haven't done a hydro rotation. So we shall now go on to the next case. Anaga, you could introduce Dr. Srini.
Very nice, Amit.
Thank you.
Our next speaker is the ever energetic Dr. Srini Edakulan from Calicut, Chief Surgeon and Medical Director of Comtrust Eye Hospital, Kannur, to show us a challenging moment. Over to you, Dr. Srini.
Do you share?
Yeah. Can you see my video?
Yeah.
Yes, sir.
Yeah. There's a narration. I think later.
Dr. Srini, the audio is not coming.
This is basically everything was okay, like till the end, like aspiration was done, and then the eye became hard. The iris started prolapsing. See, the iris could be revisited to the right foot. So there was no progressive increase in intraocular pressure, and definitely no signs. So it was not a suprachoroidal hemorrhage.
Your voice is not very clear, Dr. Srini.
Yeah, we can't hear you.
Can you switch off your video?
Okay.
Your
Would you want to present with your video voice? Because this is
No. I actually thought you will be presenting it, so I added a narration to it. So, see if I can you hear me now?
yes,
Can you hear me now?
yes,
Now can you hear me?
I can hear you.
See, if you don't mind the narration playing in the background, I'll just go back.
Yes, yes, you can have
sorry.
the narration going on because that
Yeah.
was very clear.
Yeah. So it's like at the end of the surgery, I became hard and iris started prolapsing, and I could actually reposit the iris through the side port. So it's not like the expulsive kind of hardening of no suprachoroidal. It's not a suprachoroidal hemorrhage or suprachoroidal effusion as such, because it's not drawing hardening. The visco is not going in. You put the visco is coming out, and iris is also coming out. So it's this probably all of your face. It's a misdirection of fluid into the potential space between the posterior capsule and the pupil. So the Burgess space. This has happened to me before, and this was the first time that I was managing like this. Previously, when it happened to me, I used to just stop the case, heavy mannitol, take the case after 2 or 3 hours, and all cases except for one, I could complete the intraocular lens implantation. In one case, I had to postpone. See, as you can see, like eye was already open, and I'll decompress the eye by responding vitreous. So the needle was passed to the anterior vitreous area, and a little bit of fluid is aspirated. You can see, so you aspirate the fluid from just behind the posterior capsule. It softens the eyeball. So eye is soft. Now the anterior chamber will taken more visceral acid. So till now the posterior capsule was actually bulging. Now it has fallen back, and the intraocular lens could be easily implanted into the back. There have been studies published on this fluid protectant syndrome. Recently, Dr. Maligan won the best video awards for a presentation on the fluid protectant syndrome in AIOS-ARC. See, there is a paper which has reviewed all the published journal articles on fluid protectant syndrome, and that journal and many other journals on aspiration of the fluid to decompress the eye has shown that there is a safe procedure with no retinal issues. Like in this, the postoperative division was 6, no retinal issues. But maybe it might be better if you are actually going for this decompression, it might be better to go for a small gauge vitrectomy cutter to decompress. Probably that should be the way to go if you're going for it.
Can you stop sharing? That was a wonderful video, Dr. Srini, which you showed a very difficult situation, which rarely does come upon all of us. But I strongly believe, and I'm sure most of us believe, that using a straight needle which goes transconjunctivally, transclerally into the vitreous in the retrocapsular space, you might probably rarely engage the posterior capsule itself, or you might engage the vitreous and then pull on it, and you could have a traction and a serious complication. So it makes sense from taking the advice of our retina colleagues that we use a small gauge vitrector and do this. I would definitely want the opinion of any of my expert panel on that. Dr. Rohit Prakash.
Yeah.
Are you there?
Yeah, absolutely. So I personally feel that he managed it well. The first time I saw this was way back in 1984-85 when my father put the needle and aspirated. But I think that is history now. As you have rightly said, what has to be done is we should go with a cutter, because if we aspirate that, it can pull the vitreous and create problems. That is the first thing which needs to be done. Suprachoroidal leaks should be ruled out, which he adequately did. Another important thing is for those of us who are, for I think a good chunk of ophthalmologists are not used to going through the pars plana and doing all these things. For them, what I would suggest is that if you have ruled out that suprachoroidal, you can use, make the patient wait, use IV mannitol, and then come back maybe after an hour or 1.5 hours, and that can also be done. But ideally, vitrectomy cutter after ruling out suprachoroidal, because there are pockets of fluid, because of fluid misdirection syndrome, fluid goes in through the zonules, which may be weak, or there may have been some surgery done in these patients. But definitely a big no to using a needle to aspirate.
More for the interest of the audience, I thought I'll just tell situations where you could get a fluid misdirection. I'm sure you all could add if it is a hyperopica, if it's a PI is already there, or if there's a zonular weakness through that, you could have misdirection. Even if there is a shallowing of the eye because of a wound leak, you could that could trigger it off, or even a leak during trabeculectomy procedures. But we do have read about zonulo-hyaloidovitrectomy. Mohan, your thought on that? Is it ever being done? Does it make sense? Because it is a visible thing which you can see actually that you're cutting at that area going through the PI. Have you ever done it, Dr. Mohan?
I'm sorry, I'm muted. No, I've not done that, but please understand, when you have something like a rock-hard eye syndrome, that is AIOS, acute intraoperative rock-hard eye syndrome, then you need to go in and find out, do an indirect ophthalmoscopy to find out whether you have a choroidal suprachoroidal hemorrhage.
Yes.
Before that, confirm that you don't have anything like that in the posterior segment, and then only put a trocar and cannula into the vitreous cavity. For heaven's sake, don't do this without having a look. Okay, though you may say that red glow is there, I don't see anything coming from behind, but you should have a look at the back and then put the trocar and cannula. What I do normally is I give mannitol and wait. Otherwise, I just put a suture for the main port and go with the trocar and cannula 3.5 millimeters from the limbus. And then Maipal has beautifully demonstrated some videos on that. I've also done that regularly. And wherein we just go in and do, you just have to do a limited vitrectomy. You can do actually a vitrectomy even from outside. But only thing is, don't put a needle and aspirate. If you put a needle and aspirate, problem is vitreous cannot be aspirated. Vitreous has to be cut. Okay, vitreous is a thick jelly-like thing. You can't aspirate the vitreous. If you aspirate the vitreous, you can have problem like attachment to the vitreous base and all these problems post-operatively as well. So this is, I think, the take-home message. Intraoperative mannitol, be patient, have a look in the posterior segment. then if you are okay, put a trocar and cannula. Otherwise, most of the times, intraoperative mannitol itself and giving a patient, I also give Xylocard 4% IV as well. It works very well. I don't know how it works, but it works very well. That also reduces intraocular pressure. And also make sure the patient is also very calm. Midazolam you can give at that time. Ask your anesthetist to give midazolam, and then you can go ahead with the patient after some time. As Rohit said, you can wait.
Yeah. Hi. Just a quick thing to what Dr. Mohan Rajan sir said. I remember in ECC days, people used to get expulsive hemorrhage. But last 20 years, I've never seen an expulsive hemorrhage happening in a case of phaco. But many people here have been doing surgery for way longer than I have. So anyone has seen an expulsive hemorrhage actually in a case of phacoemulsification while phaco is going on? I'd love to know, because I've never seen one, and probably I've only seen or done 20, 30,000.
No, it is
People
possible.
Collectively have done millions here, and but I've never seen one.
It is possible.
I have seen a couple.
I have
had long time back a patient with expulsive hemorrhage, a patient who had a very old patient, brown cataract, little small pupil as well. Please understand this ARIES is also very common in patients who have got high myopia, brown cataract, pseudoexfoliation, small pupil wherein there can be zonular weakness and the fluid goes behind and pushes the posterior capsule, increases the positive vitreous pressure as well. So I have seen expulsive hemorrhage, not so common, but definitely you have to keep that in mind always when you have a rock-hard eye underneath. Yeah.
Dr. Ramurthy, you have anything to tell?
No, regarding Cyrus's question, obviously expulsive hemorrhage does occur. It's not only because of the features in the eye, because of the nature of the patient also, extremes of age, hypertensives, etc. The only thing is when we were doing intracapsular, extracapsular cataract surgery, there used to be a huge incision because of which all the iris, vitreous lens, everything used to flow out. With phaco, because you have a small incision, we are able to have the time to just close that up. But then there have been a couple of occasions post-operatively where I found that the entire choroid and retina is disorganized and the patient ended up with no vision. Obviously, just because it doesn't come out, it doesn't mean that the expulsive hemorrhage is not there. And otherwise, I think that's the only comment I have.
So,
yeah, Chitra.
I think that is, you get limited suprachoroidal. So that basically because of the small incision, it's like giving a tamponade. Whatever the first thing you do is put up sutures and close the eye. That's already a closed eye. Yeah. And whenever you get a hard eye, so what Mohan emphasized, I'll re-emphasize that you have to root out choroidals. That is very, very important. That is the thing. And what he did say, we have described limited pars plana vitrectomy, where you actually don't need to go in to remove, because if it is an aqueous misdirection or a fluid misdirection, it will just come out from the trocar cannula that you have put, and you don't actually need to do a vitrectomy and disturb the vitreous if it has not been disturbed. So that is something which is very, very important. But Cyrus, you do get expulsive specifically because we do a lot of combined surgeries with Dr. Harsh there. And bad glaucomas, high intraocular pressure in patients who have been there for a long time, those are also apart from the other factors which Ram just elucidated as it is. So it just remains limited in phaco as compared to an ECC or an ICC where you had a larger incision. That's about it. So at times...
I've had an expulsive hemorrhage the next day after a trab, where patient came and all the contents were under the conjunctiva.
My God.
Chitra, can I add one point? Just before the COVID, or 2 years back, I had a patient with anophthalmos. I was operating, one eye went on very well, the other eye, all of a sudden, the expected, the intraocular pressure went up, and I had an expulsive hemorrhage for the patient. And obviously, I couldn't put the lens, and then subsequently, after a week or so, then we did what we call vitrectomy, and the patient is having 636 vision now with aphakic correction. But what I'm trying to say is, in anophthalmos, please understand, in anophthalmos, I put a trocar and cannula, okay? And I put a trocar and cannula by mistake, I did it. This happened about a few years back, and please understand that because I was discussing this with Bobby Osher in one of the conferences and said, in anophthalmos, you do not know where the pars plana is.
Yeah.
Nobody knows, okay? Because it's a small eye, it's only 16 millimeter, 17 millimeter. You do not know where the pars plana is. So you cannot put a You cannot measure 3 millimeter or 3.5 millimeter and put a trocar and cannula. You will burn your fingers. So that is, I think, a take-home message I want to give.
Yes, yes.
For all. Yes.
Can I add?
Who?
Can I add?
Srini wants to add something.
Yeah, see, I've discussed this with actually Dr. Boris Maligan. He is one of our guest faculty. He is not in favor of even going for the pars plana vitrectomy. He says, hope you have all seen his video. It's a beautiful video, and he explains those lens microparticles that you see behind the capsule sometimes, like no issues at all. You see some lens microparticles behind the PC. He says those are the cases in which you have some zonal weakness, and in those cases, his video shows that beautiful intraoperative OCT, which where the fluid goes in and separates the Burgess space. So he's actually not even in favor of vitrectomy. Just wait, like. Personally speaking, and even I would say, wait. I have one of the patients I actually postponed and did it after a week. It's just, I was taking a risk presenting this. I presented it in the coaching of the Tenville, and before presenting, I asked Dr. Gopal and Dr. Thomas Siri and retinal surgeons, should I actually present it? They said, yeah, it'll raise a discussion, fine. Okay, this is what I did. I know that I get value. Okay, let's have a discussion here.
Yes, it's worthwhile. It does bring up a discussion, and people are doing it. And I think it needs confidence to show these cases. It was very good. I heard your voice overlay. It was even better. We shall now go on to our next speaker, Dr. Madhu Shekhar. He was the chief of the intraocular lens and cataract services at Arvind Eye Care, Arvind Eye Hospitals, Madurai, who's going to show us how to bail out a difficult moment. We look forward to hear you, Dr. Madhu.
Good afternoon, everyone. Thank you, AIOS-ARC and Dr. Chitramurthy Madam for giving me opportunity. So I will share my video, Madam. So I'm going to present surgical management of a case with bilateral coloboma using phacoemulsification in one eye and manual SICS in other eye. And my patient is a 39-year-old young lady with bilateral chorioretinal coloboma and lens coloboma and nuclear sclerosis of grade 3 to 4. So first eye I planned with phacoemulsification and placement of acrylic IOL. So rhexis was intact, but it was slightly eccentric near colomatous area. You can see that during hydrodissection, there was a split in the colomatous area, but I thought I will proceed with phacoemulsification. First chop was attempted, but during second chop, it started tilting. So I put dispersive viscoelastic and retrieved the nucleus in the anterior chamber with the help of Sinski hook. And then I plan to convert it into small manual small incision cataract surgery. I shifted my site from temporal to superior side. Sclerocorneal tunnel was fashioned. I was in early stage of phaco, so I decided to convert it into SICS. Nucleus was extracted out with the help of irrigating practice. Automated vitrectomy was done, and then I used Simpo cannula using dry aspiration to not to hydrate vitreous much. After aspirating all cortex, I placed a 3-piece acrylic IOL in the sulcus and centered it. The second eye of same patient, that there was nucleus sclerosis of grade 3 to 4, and lens glaucoma was slightly larger. So I planned for manual small incision cataract surgery instead of, because in first case, there was nucleus was about to drop. So I planned for small incision cataract surgery. In this eye also, I was careful during capsulorhexis because there was a split in capsulorhexis in the first case. So I was doing capsulorhexis at utmost care at the area of coloboma. I completed the rhexis. It was a continuous capsulorhexis. I tried to make a slightly larger capsulorhexis in the area away from the colobomatous area so that I can prolapse out the hard nucleus. Then very gentle hydrodissection was performed. And then I used a bimanual technique to prolapse out the nucleus out of that and to relieve the stress on the capsule. Then I extracted the nucleus out with the use of irrigating practice. But in this case also, after removal of nucleus, I saw there was a split in capsule near the colobomatous area. After cortex aspiration, 3-piece acrylic IOL was placed in the sulcus and case was closed. So in both the cases, actually the rhexis was complete, but it split off near the colobomatous area with a minimal amount of force. So take home message will be from my side that we should make rhexis smaller in the area of coloboma and slightly larger away from the area of coloboma, and any maneuver should be gentle and always ready for managing this type of complication with 3-piece IU. Thank you.
That was a wonderful learning, and it's always safe to convert if in doubt. But these were my thoughts. I think most importantly, we should create a smaller rhexis well away from the area of the colobomatous area. And if the flap, you look at the flap eversion and inversion sign, which Dr. Rohit Om Prakash tells, which makes so much sense. And unless the nucleus is tilting, I don't see any reason that we need to convert it into an SICS. We could go ahead and complete it. But in any of these eyes, one question which I have to all of you is, would you believe, keeping in view that there could be a zonular weakness in that colobomatous area, would it make sense to use a CTR? Because I do understand that these are eyes again, which can have a fluid misdirection. So if you place your CTR beforehand itself and go on with the surgery, that is one preventive measure. And does it at all make sense to do a pupilloplasty in these eyes? Dr. Namrata?
So I think I wanted to ask Dr. Madhu one question, and regarding the CTR, I don't routinely put CTR in all these cases of coloboma, but I don't know if there are other studies and if others do so. Having said this, Dr. Madhu converted in the first eye and then in the fellow eye planned SICS. I think
Yes,
I would have
madam.
started again with FECO only in the fellow eye.
No, I started with SICS only, madam, because nucleus grade was slightly harder in this eye, and there was a larger colobomatous area in the inferior side.
Okay.
Anybody's thoughts on whether it could have done a
Yeah,
favor?
Chitra. You managed very well. I mean, and you did.
Yeah. No, it's,
yes.
I was trying to make a point that in the colobomatous eyes, the capsule is always weak. Even capsular hooks give away. Nothing really works. So I would go with Madhu with his experience in the first eye. He did a SICS in the second eye was perfectly justified, because in the capsular strength that this lens had, it would be very appropriate not to try anything, because you recommended a small capsulorhexis, all to use maybe a capsular hook if it gives away, but most commonly the capsular hooks give away in the colobomatous eyes where the capsules are weak actually. So I would go totally with Madhu. What he did was absolutely right and well done. The other thing, probably, if you are too adventurous on phaco, these cases also have a zonular weakness, and probably you do a pars plana vitrectomy and then go ahead with the cataract. That is a different scenario altogether.
I'd like to slightly differ from what was in the sense that I think Madhu has done what worked best in his hands, and obviously the ultimate outcome is what matters. But in these cases of congenital coloboma, it's only in the area of the coloboma that the zonules are weak and are absent. And it's rest of them, you said 37, 38-year-old. Obviously, even the way you got the rexes, it appeared that the zonular support is quite adequate. And it was just a coincidence that in both these cases, you had a rexis runoff and a wraparound, and you ended up with in the first case, with a vitrectomy being required. But I have done quite a few and usually do a phacoemulsification and just making sure that the capsular rexis is well away, the margin of the capsular rexis is well away from the area of the coloboma. I do not believe that these capsules are any more weaker, or even the zonules are, the strength of the support for the lens is any weaker, because except in the area of the zonular weakness, the rest of the area zonules are intact. And normally we can go ahead and do a conventional phacoemulsification, of course, keeping exercising a little extra care. And there have been occasions when there have been extreme colobomas where the entire pupil is drawn to one direction. In those cases, that's just a tip not relevant to this case. I just enlarge the pupil a little more because you want the optic of the lens to be seen through the pupil that is there, because some of these pupils are a little drawn to one direction. But otherwise, I think phaco usually works well in these cases. You had this problem more because the wraparound of the rexis tab that occurred rather than the problem of the coloboma being there.
There's also this logic about placing a CTR, not just for the weakness alone. It actually, these are the eyes where there could be a fluid misdirection. So placing a CTR beforehand after creating the rexis is one preventive measure, which has to be kept in mind.
No,
yes,
but
I agree with
these studies and literature to support that people have placed CTR in these eyes. And another thing is that you should always operate these cases earlier rather than later, because later it becomes even more complicated because the cataract becomes harder
Very
and
hard.
more difficult. So it is better that you do them earlier rather than later.
So Dr. Namrata, could you just explain again as to why putting a CTR is counterintuitive?
No, I'm not saying it is counterintuitive, but I'm saying that there are no studies to support that it is going to help, at least in the published literature, maybe in the personal...
published, but from a clinical perspective...
Yeah, unpublished, it may be there, but I have not come across, because we were doing a review article on colobomatous eyes, cataract and colobomatous eyes. So we did not come across, any published studies of large cases.
I would tend to agree with Namrata, except for the zonular defect in the area of the coloboma, the rest of the zonules are intact. So,
Can I add something, Chitra?
Get an additional support. There is no harm. Some people,
no harm.
So I couldn't agree with I agree 100% with what Ram said. I would go ahead with a phacoemulsification. I would not consider that because maybe I don't know how to do an SICS. But the point is that it is a localized defect. It is not a generalized weakness. And as Ram said, the proof in the pudding lies that you could easily get a capsulorhexis. If you had a generalized weakness, doing a capsulorhexis is a problem. If you can do a pre-chop with a that is the best. Normally, what is very, very important also to remember is that the parameters needs to be a little. That's about it. Apart from that, I would always put a CTR. And a capsular hook also helps in case there is any problem. You normally don't get a vitreous coming out. I have done lots and lots of these colobomatous eyes, and these behave in the same manner as anything else. One other thing too important is that if you put a lot of trypan blue, at times you lose the red glow, because the trypan blue tends to migrate backward. So if required, use a trypan glue, but otherwise use minimal quantity, and just see that you are not overdoing it, because it tends to obscure the good red glow that you have because of the posterior percolation from the defect area.
Mahipal, can I make a point, please?
You already made your point, Mohan.
Yes, sir. Yes, sir. No, you can make your point, sir. No problem. You are a past president. I'm a president.
What I was trying to say is,
yes, Dr.
yeah, I mean, what I was trying to say is, if there is a zonular, like Dr. Madhu did nothing, that should have given the rhexis away. Now the rhexis went away. Now he did a rhexis and it was done well. Now why did the rhexis go away? That is the point.
We will need to review.
Did he hit it with a chopper? What did he do? That is what I'm saying. If there's an inherent weakness in the capsule.
No, sir, I will not agree with you, sir.
Sir, I have never had.
No, I will not agree with you, sir. I want to stress that point. I fully agree with Ramurthy and Mahipal. It's only a localized one. I put the CTR at the beginning. I start with capsular hooks. I put 2 or 3 capsular hooks. Okay, I don't put only one capsular hook. I put 2 or 3 so that there's equal stress on the tension on the back. And I've not seen a single case of a lens or a capsular rhexis or the anterior capsule getting split in these patients, and able to go ahead with the phaco without any problem at all. Of course, in coloboma, as my Namrata said, if you leave it for a long time, they end up in a very brown, black cataracts. Those cataracts, probably I will do SICS. But these cases, routine cases, grade 2, grade 3, I think this is the way to go. And there's no way, I think, I feel that it's only a localized, just like a traumatic cataract it is. In a traumatic cataract, there's a localized zonulopathy. Similar to that, there is a localized zonulopathy in a lens coloboma or iris coloboma.
I think whether phaco or SICS, whatever is surgeon's comfort zone, whichever he is confident with, he can go ahead. By first case, what Madhu did, he saw what were the complications, what were the factors. So he to second eye, he took as SICS. So it's surgeon's comfort zone which should be taken into account,
I feel this,
and not the technique, whether it is phaco or SICS.
No, that is right. That is right. What I was saying, I feel that phaco has got enhanced safety in such a situation. There's a better intraoperative control than an SICS. You saw that SICS, when it tried to deliver the nucleus, how much of stress was there on the zonules. In phaco, it is not possible because everything is taken care in a phaco.
I disagree. Surgeon's choice.
Dr. Amit, I fully disagree. That carry home message should not be that you should go in for SICS because you had an extension. He had an extension. It was in the area of zonular weakness. He should have converted early. Phaco, by all means, if you are a phaco surgeon, by all means, definitely there is no to it. It is a definite yes with all the techniques, and this is not. We should definitely not emphasize that SICS is the preferred technique. If you
it is not preferred. Surgeon's choice. Whatever he is comfortable and confident, go ahead with that technique.
That is fine, but we cannot say what Rohit is saying that
I understand.
Of SICS over phaco. There are enough and more advantages of phaco over SICS, specifically in a coloboma. So there should not be a wrong message taken home that if you are dealing with a colomatous eye, you should preferably switch over to SICS. I don't agree with that.
I don't agree with that.
I would 100% contribute to emulsification. Also, I am not comfortable with SICS, but I have not had problems. So getting from one particular case, and what Mohan has said, the whole thing, the way you are collapsing and the way it is, there's more stress on the zonules than it would be with a phaco. With you have an endocapsular ring and you have capsular hooks. The things are very much under control.
So regarding the capsular hooks, if there is no phacodonesis at the time of doing the rhexis, then would it be really required? If at all there is phacodonesis and you feel that there is a zonular weakness, only then would a capsular hook and a CTR would be required.
No, the capsular hook is just giving support to that area of weakness. Okay, that area of weakness, so that there is no stress on that capsule, that area.
I feel if there is a significant phacodonesis and you feel that there is instability, then I would go ahead and put a capsular hook or a CTR.
The basic concept is that when we are giving a support,
Yeah,
in
it
the
gives
form
us
of capsular hooks.
it does not, because wherever there is a weakness, it tends to increase.
Yes.
So if you have a support, it will support, it would not allow it to extend. And like this is a hard cataract, I would put a capsule. If you are dealing with a softie, then it's very easy to do a hydrodisc. Like you are doing a posterior polar, you just scoop it out and you don't put any stress on these zonules. So that way it would be all right. But
You mentioned about flax also. I think your voice broke in between. Did you mention about the use of flax also in these cases?
there is no issue in doing a flax because you are pre-chopping the nucleus.
Yes, because I have used flax. I didn't hear you clearly at that time. Your voice cracked.
The only problem
One last question.
Chitra,
ophthalmic eye with a small eye with a coloboma, getting a good suction, I was not getting a good suction at all. Plus the OCT doesn't come. So if you are dealing with a 16-17 millimeter eye, neither does the OCT come. You have to try and fix all thing, and you don't get a good adequate suction because they don't have any suction ring or a LOI for such small eyes. That's all. But otherwise, Phaco, you won't have a problem in capsular access. You don't have to be away from the zonular, and you have pre-chopped the nucleus, so you can easily remove it.
Can I ask one last
one question, Chitra, one question.
No more discussion. Go on.
No, Chitra, I mean, how was the first situation that Madhu was in? We dealt with the first situation where you have a capsular rhexis tear and the nucleus going down. How would a surgeon retrieve this? Tell me.
You could look at this area of that rhexis flap, whether it's everted or inverted, and you could, that was a very soft, not a dense nucleus. You could easily do a phacoemulsification, keeping an eye on that area of rhexis weakness and get away with it. The last question which I want is, would you want to do a pupilloplasty in this particular case? Be one expert panel to comment, or it doesn't make sense, then we go on to our next speaker.
No, I don't think you should.
I don't do.
Because they already have an area of fixation and they are fixating from there.
We are not going to be discussing other things. There are too many speakers who need to be given
People has been lecturing for a very long time. Please give her a chance.
No, I just wanted to ask her the same thing because I've had decent experience in the coloboma, and I agree with you that they do not have generalized zonular weakness. And I've done pupilloplasty in number of cases, and what I realized is it doesn't make any difference. So that's the point I wanted to make.
Thanks a lot. That was good discussion. We go on to our next speaker.
Ma'am, I just want to congratulate Dr. Madhu on behalf of ARC and Bihar Ophthalmic Society. Dr. Madhu has done his post-graduation from Patna Medical College Hospital, same place from where you did your MBBS. So I want to congratulate him for the beautiful presentation he made.
Yes,
Thank you.
Amazing surgeon. We all know that. He showed a very good topic for discussion. So we go on to our next speaker, Dr. Ravi Challa, a leading cataract and refractive surgeon, a pioneer from Hyderabad, to give us his pearl, and a good one at that. So let's hear from you, Dr. Ravi.
Yeah, this is a routine stop and chop case which turns strange.
Interesting case here. So of course this is a white mature cataract, and he's going to use the double rhexis technique. Going to make a small central capsulotomy, and notice this is done with just a paracentesis incision, so that the anterior chamber is highly pressurized. Then the second rhexis can be done afterwards, and you can see that looks beautiful. Beautiful rhexis here. Sculpting a central groove now for a stop and chop type procedure. Everything looks pretty routine in this case. So nice good central groove, and then going to crack this and split it into two halves. And as a result of having a thick fibrous posterior plate, you don't get a good separation here. So that's, you see the nucleus is split, but not centrally. So now more viscoelastics going inside the eye, and then he's going to use a couple of Sinski hooks to do some manipulation, try to separate the nucleus. Here's where I want you to watch very carefully. As the two halves are separated, look how far apart they are. Look at that huge gap between the two pieces. Wow, where's the piece that's subincisional? There's that last bridge that's being broken. Now we have two fully separated halves. But where's the proximal heminucleus? It's under the iris in the subincisional space. Where did the nucleus go, the heminucleus? Well, half of the heminucleus has gone through a defect at the capsular bag equator. So the subincisional capsular bag equator. So the surgeon here, Dr. Challa, is going to phacoaspirate and chop up the first heminucleus. Going to just take his time there. And again, the second heminucleus is still under the subincisional iris. Very unusual case. To have a break or a violation of the capsular bag at the equator is very unusual. I'm very thankful for Dr. Challa for sending this case, because this is something you don't see very often, at best once every few thousand surgeries. So now only half the nucleus is gone. One heminucleus is gone. The second piece is still there, and it's underneath the subincisional iris. Look, it comes forward. As the anterior chamber is depressurized, that piece comes forward again. So as you pressurize, it disappears. So we need to get that piece up. Under the iris goes this Stinsky hook, and we're going to bring that piece centrally. And Dr. Challa is going to just take his time here. And he's going to do a beautiful technique here. And it's still stuck. There's the heminucleus. You can see it. Now, we don't advocate fishing in the vitreous cavity. That's going to cause issues. But here he's doing it in a very safe manner, and the piece is not in the vitreous cavity. It's through that defect, but it's not floating in mid-vitreous. And here he successfully brought the second heminucleus up, more viscoelastic, create a barrier, keep that second heminucleus up. And he's also very smartly using that nasal angle, keeping that piece pushed against the nasal angle is very good, because that prevents it from slipping through the pupil. We don't want that to happen. I'm really happy that we're able to watch and learn from this masterful technique. It is absolutely safe. Now, would I have faulted you if you said just let the piece go back and have my vitreoretinal colleague do a pars plana lensectomy? No, that'd be perfectly fine. And in some cases, if you're unable to reach the piece, I agree. Let it go. Don't fish for it. So now that the nucleus is entirely removed, he's going to fill a capsular bag here. He's going to insert the lens. So there's the viscoelastic being put in the eye. Here comes the IOL. Now, what are your options here? He's going to do a hydrophobic acrylic single-piece lens in the capsular bag. As long as you rotate it 90 degrees away from that defect, I think you'll be okay. Other options would be a 3-piece lens in the sulcus, again with the haptics rotated 90 degrees away from the defect. And finally, at the end here, the viscoelastic can be removed. So, very good technique. We really enjoyed this very unusual case. Again, capsule rupture or capsule defect at the capsular bag equator in the subincisional area, and half the nucleus disappeared and then came back. And at the end, it ended up beautifully. Thank you for watching.
Dr. Ravi, that was can stop sharing. That was a wonderful video which is going to have a lot of discussions. My thought about this particular case was that must have been a very small PCR, and the vitreous would have been a jelly-like structure there, and so you could do it. But one thing you could have, while hunting out or scooping out that fragment, you could have actually placed an iris hook to get a better visibility rather than digging there. The other thing is, we also need to keep in mind at this point that if that area of PCR were to increase, these are the cases where we could do a pars plana vitrectomy so that you contain that area of PCR, it doesn't become big. My second thought was, since we know that the nucleus has sunk there, we know there's a PCR there, when you brought it out into forward into the capsular bag, probably you could have thought of putting an IOL scaffold in these eyes, because that was a fairly large chunk, and then going ahead and removing it. I want the thoughts of the experts in this.
I have a point to make. I don't think that there is a PCR. If the PCR is there, the posterior capsule will not be taut, and the red reflex is clean. No creases in the posterior capsule also. So it must have been a rent in the equatorial region only. So the zonules are holding the anterior capsular rim and the posterior capsule also. So that's why posterior capsule is taut throughout the procedure.
No.
So I also
Is the patient a high myope?
Vitreous could have come from.
I don't remember.
What was the power of the lens? what was the power of the lens that you would have put?
Yeah,
Because
he'll be high myope, that's why.
yeah, it is a high myope. Then the lens in that case would, go underneath the iris and only come out when you deflate the anterior chamber and it kind of becomes shallow, then it keeps popping out. Also, I think when you can't get a full hemi section like that, then it's best not to attempt to make it a hemi section. You can just have a crack there like a pie or like a pizza thing, and then, carousel it, and then I have another one and take that pie out rather than, trying to make that 180 degrees cut from one end to the other end.
Yeah, Chitra, can I add something?
Yeah.
Yeah, first things first. Chala, fantastic video, is really incredible stuff. But I want to know why, see, this stop and chop, especially for a hard cataract like this, you need to go all the way down, almost 90-95%, and then try to crack. Then when you're cracking, when you're doing the first crack, I noticed you are more anterior than posterior. You need to go posterior and crack. Then only it will crack nicely. If you're anterior, every time you crack and do the lateral separation, there'll be stress on the zonules. So that is what has happened probably. And then again, you try to crack and go in and crack with a second instrument or a Sinskey hook or something like that. But again, there was so much of pressure on the lateral, the vector forces were very high. And that is probably the reason for the zonule, this thing. Third thing is I agree with Chitra, because when you see something underneath the iris, I'll put one or two iris hooks there and know exactly what is happening there. Okay, so because I never saw you using tricot at all. How do you know whether the vitreous is there or not? We do not know at all, because you have so much of manipulation is there. 100%, you cannot just have a nucleus there lying there in the equatorial space without the vitreous coming in front. So I think these are all the small points, but otherwise beautifully handled.
Om Prakash had a presentation similar. That could also have been an area of zonular weakness, and because that nucleus fragment was there, it was pushing that area of zonular weakness. So you can never be sure that the vitreous will not come forward in that area.
Yeah,
Dr. Mohit, do you have anything to tell there?
I think it was a very nicely presented case.
Yeah.
Well, if you are not able to separate, just forget about it. Move ahead and chop other pieces eventually, and and then you can, while emulsifying with the stock, joint, you can emulsify the stock and the pieces can be separated. Separation should not be that aggressively managed in all these patients. The second thing, which it's something which I would like the discussion to be initiated. I have seen that in some patients wherein the hyaloid, if you have a PCR, the hyaloid face is intact. Suddenly you feel that the nucleus has gone behind, and suddenly when the chamber collapses slightly, the nucleus piece comes up on its own. So if the hyaloid face is intact in some cases, the nucleus piece behaves in a very extraordinary way in coming up. But once it is broken, then, it goes, there's no idea of fishing. And I fully agree with Dr. Mohan Rajan, by all means, that this separation would have led to some equatorial, the capsule giving away, and having a view with an iris hook or whatever it is would have been obligatory and mandatory rather than, just trying to pull it out.
Just one more thing, Chitra. Dr. Vasavada has described a beautiful technique of multi-level chop. So if you are anterior, which like Dr. Mohan Rajan said, and it's not splitting, go a little more down step down, and with the help of the phaco probe, and then again try. Then it kind of works out.
I think I'll be just reiterating what was said in the sense that what Navatra said may be applying to phaco chop, but as far as stop and chop, which is still widely practiced, the only thing I would have done differently is if it did not chop easily, I would have gone back again with a phaco probe and made a trench much deeper instead of putting in so much power on splitting the heminucleus. And also, as was emphasized, I think going into the depth of the nucleus is extremely important so that it just simply gives way and there's hardly any stressing. And I feel that maybe what he did was absolutely right in the sense that posterior capsule is intact and that there was no vitreous disturbance. And as the chamber shallows, the nucleus fragment just floated into view and he went ahead and completed. Maybe there was a capsular dialysis in the periphery, but that would not have changed the management of the case, especially since he's positioning the haptics away from the area.
If there was a dialysis, you should position your haptic there to keep it stretched, a 3-piece IOL for that matter. But that was a wonderful case, Dr. Ravi. I was so excited when I saw that there will be a lot of discussion. Anagha, could you introduce the next speaker?
Dr. Pradeep Mohanta, sir, has he joined?
Yes, he's joined. Dr. Pradeep, you need to unmute yourself. Dr. Pradeep?
Sharing your screen in the meantime. Yeah. Dr. Pradeep Mohanta is the director of Netra Jyoti Eye Hospitals, West Bengal, and he's a teacher par excellence. He has contributed majorly through his video library, and today he'll be enlightening us. Over to you, Dr. Pradeep.
He was here. Dr. Pradeep?
He's there.
He's muted.
No, he can hear us. No, he has to share his screen.
Share his screen.
Dr. Pradeep, can you share your screen?
No, it is with you.
No, you have to show the video. I kept writing in the group.
Should I share now?
Yeah, yes, Mr. Sunil, you share his video. It's a wonderful video. You could share. In the interim, yes.
This is a very hard cataract. The purpose of this video is to show that I get clear cornea next day if I employ submarine chop in such rock-hard cataracts. After a large rhexis and gentle hydrodissection, the antechamber is filled up with hydroxypropyl methyl cellulose, and then the tip of the phaco needle goes in with its bevel down, some superficial cortical lens matter is removed, and then the handpiece is turned to make the bevel up. Now, with the help of this chopper, the nucleus is pushed a little down and the tip is buried into the substance of the nucleus just in front of the main incision. It goes through the substance quite some distance and goes near the opposite equator, and the nucleus is chopped. A very good crack is obtained. 180-degree rotation and few scalps, and along the initial crack, the nucleus is divided completely into two heminuclei. And this is the larger heminucleus. I'm going to divide this into 3 pieces. This is one, and this larger piece is again divided. So we get 3 separate pieces from the larger heminucleus. Come to the other heminucleus, and it is divided into 2 pieces. So we have got 5 pieces. And now we're going to emulsify these nuclear pieces. Phaco power used is 80% in continuous mode. Flow rate is 45 ml per minute. Vacuum is 450 mm of mercury. Emulsification of the triangular pieces is carried out starting from its apex. Look here, the piece is tilted and emulsification is started from the apex. Emulsification of the pieces are carried out in the anterior part of the capsular bag, just below the iris plane. One more thing you can note, that no small pieces are running here and there, and it is not hitting the posterior corneal surface, not hitting the back of the cornea. They come after emulsifying half of the nucleus, refill the anterior chamber with 2% SPMC, and again go in and emulsify the last 2 pieces. When I use SPMC, hydroxypropyl methyl cellulose, this is the strategy in hard cataracts. Come out after emulsifying half, refill the SE with SPMC, and again complete the case. This is the last portion of the last piece. At this time, I come to phaco on mode where the vacuum is only 80 millimeter of mercury. And thus the nucleus management is completed, cortical cleanup is done, and an intraocular lens is implanted. Now see the post-op pictures just after 18 hours. Crystal clear cornea, anti-chamber quiet, unaided vision is 6/12. Thank you very much.
Thank you, Dr. Pradeep. That was a very daring surgery. Very good. That was a new tip. But I do feel that your rexes were nearly 6 millimeters in these eyes to go ahead and do your submarine chop. I think for premium IOLs, when you are very particular about having a smaller rexes, what is the opinion of the expert panel? And one thing I want to ask Dr. Pradeep, could you tell us the parameters which you have used through the course of the surgery?
Yes, can you hear my voice?
Yes.
Yes.
Yes, sir.
Yeah. The phaco power was 80%, flow rate was 45, and vacuum was 450 millimeter of mercury. The machine is Oakley CATARACT 3.
You also mentioned about continuous mode.
Yes, yes.
Continuous.
That your routine for these hard cataracts?
Yes.
Also
yes.
do the burst mode?
No, continuous.
Can I ask?
I think that is, may I comment on that?
Yes.
No,
Yes.
beautiful demonstration. I mean, it worked very well in your expert hands. But I think the reason Anaga asked was, I mean, this doesn't have the ellipse or the ozel. Obviously, it's also an excellent machine. But most often, I would have gone for a interrupted power in this case, pulse power, because even though it was a very hard cataract, even in these situations, it would do well. And even though you kept emphasizing HPMC, I also generally use HPMC. But this is one of the situations where I would like to use a combination of hyaluronic acid and chondroitin sulfate. Something like the Viscoat now, very good Indian alternatives at a cheaper price is also available. The other thing is, though you chopped it beautifully, I think in these hard cataracts, I would, in the subincisional area, I would create a small trench. And that gives me a good approach to the meat of the nucleus and helps me to create the first chop in a more controlled manner. Otherwise, what you did seemed to work very well. But I would slightly differ on the settings, because even in these hard cataracts now with the modern machines, I think 80% continuous is not needed, and you could get away with a slightly more gentler settings.
Chitra, can I add?
Yes, Dr. Mohan.
Pradeep, nice presentation. In fact, we had this discussion. Ramurthy also knows about it in the Shankar Netrala alumni webinar. The same case, submarine chop you showed. You had a good rexis, fairly good rexis. I use about 5.5, which gives us the space, especially because these are all very big cataracts. But these are about blown black cataracts, what you showed just now. And I would suggest that using the continuous phaco power 80%, 100%, and bringing the nucleus slightly up and using only HPMC. I can't guarantee clear corneas like you. I'm very, in my opinion, I cannot. I use Viscoat for all these cases. I use hyperpulse of the cold phaco because that minimizes the phaco energy. Whatever you say that the last time you were mentioning about the phaco energy getting delivered into the nucleus. Please understand, if it's getting delivered only into the nucleus, ultimately the energy, the heat has to come to the endothelium as well. So I can't understand how the corneas can be clear with the continuous phaco energy you're using, so much of phaco energy you're using, and also you're not using any Viscoat or any dispersive viscoelastic for that matter.
Plus
So,
more chance of a wound burn also. Surprisingly, there was no wound burn in your case.
He is a great surgeon, but
he's a fantastic surgeon. No, full marks, Pradeep.
Absolutely.
No, that's what I'm trying. I want to learn from him how he is able to deliver clear corneas, because I do these cataracts regularly. I use my sharp chopper. I do the vertical chop. I don't do the horizontal chop or the submarine chop like you, but I use the vertical chop, and I use Viscoat now and then into the anterior chamber repeatedly. About 3 or 4 times I use Viscoat, and despite the fact that I'm able to deliver, crack these cataract or chop these cataract into multiple pieces as well. And I use always the hyperpulse or the micropulse or the Ozil or the Ellipse or whatever whole phaco technology which is available with me.
I think one other observation.
I also don't use Viscoat. I always use HPMC. And mind it, the corneas are clear. So I really don't see that it is obligatory and mandatory to use Viscoat for that matter. Continuous is something, yes, something which, but deeper plane emulsification, dividing into smaller pieces, keeping the nuclear pieces away by using a chopper shield at times, using Visco dispersive coating like with the HPMC will also suffice in these patients. So these are the few things, but I really don't agree that you have to use Viscoat is obligatory and mandatory. Even if you're doing deeper planes, smaller pieces, chopper shield for that matter, I think that should suffice by all means.
Maybe as a message to be sent across to the general routine cataract surgeon. For a panel like you all, definitely it may not be required, but if you have to send a message across, then maybe it would be prudent to use it.
Rohit, there is enough and more evidence to show that the endothelial has receptors to bind to chondroitin sulfate. It does not happen with to that extent with sodium hyaluronate and does not happen with HPMC. So these binding of the chondroitin sulfate to the receptors of the endothelium gives the additional protection, and it does not wash away to that extent or that easily because of this binding. So that is first thing. Chondroitin sulfate, I think without dispute, when you go on to BSS plus, that also without dispute, cold BSS plus that would be. So these are a couple of things that you need to actually look at. You are absolutely right, Mohan. Just a point which Rohit also made. If you are actually using a lot of energy deep into the nucleus, it does not dissipate to that extent. It is the anterior levitation that you do which causes the problem. And one observation that I just wish to ask from Dr. Pradeep is that normally whenever you are doing a hard cataract, in his case also, he was using a large bore phaco needle. So that I never go on to the thinner and the bent and whatever the needles which are provided by some companies which have a thinner lumen in between, because they get invariably stuck. If I am using an infinity with such a hard cataract, I have to really flush it because it really gets stuck again and again. But if you go on to a signature machine and you are using the larger bore of the needle, then these get sucked up very easily. And that is the other thing, that don't go to, but you have to be a good surgeon like Dr. Pradeep, because the fluidics will be high. And if you are using a large bore needle, that the surge control mechanism should be good. So whenever we are on a large bore, on a very rock hard cataract, a large bore needle would be there, and being away from the endothelium is the key. And whenever you do a large capsulorhexis, one of the things that happens is that you tend to come reflexly a little forward, because the whole thing is tending to come forward. And that is Rohit's technique of keeping a chopper in between to keep the whole thing behind is very, very important. But Rohit, chondroitin sulfate Indian is pretty cheap, and the quantum is pretty low, 2 ml. So you can actually use them in a couple of cases.
Just to add one more point, Chitra, just adding one small point.
Gets washed away as soon as you put the phaco probe inside.
Viscoat doesn't get.
No, Viscoat you have to aspirate. It takes time to aspirate Viscoat. So,
Viscoat is a must for all these hard cataracts.
So one small point I wanted to make was that there are sometimes small fragments which remain at the wound site, at the main wound, and in the iris crypts, which, in the hard cataracts, we often escape our attention, especially when we finish the case. So always it is best to, when you're putting the instruments, always best to check this at these sites, the side port and the main wound and the iris crypts, that there are no small fragments which are, hidden and remaining there.
Very important point.
Very much. We go on to our next speaker. She's none other than Dr. Tamilarasi, the Senior Consultant Cataract from the Eye Foundation Group of Hospitals, a cataract surgeon and a phaco trainer, quite brilliant, a patient teacher and a very sharp intellect. And she's going to tell us some more learning. On to you, Dr. Tamil.
Thank you, ma'am. Good afternoon, all. Good afternoon, all. Coming back to basics. This video reviews the concept which is very important for a beginner surgeon to have better control of iris during cataract surgery. Iris prolapse is a minor complication and yet a challenging one that cataract surgeons prefer to avoid. This can turn a simple surgery into a complicated one, causing surgeon frustration and patient discomfort due to increased post-op inflammation and iris defect, all of which decrease the quality of vision and reduce patient satisfaction. When the iris prolapses, the surgeon usually has the time to evaluate the situation and determine the underlying cause. IFS is arguably the biggest risk factor. Improper wound construction is another factor to be considered. Here in this video, I will be discussing how to prevent and safeguard the iris which prolapses due to pressure gradient with too much of viscoelastic or BSS inside the anterior chamber. With high pressure behind the iris and low pressure in front of it, the iris is going to follow the pressure gradient and prolapse out. I see iris prolapse most commonly during hydrodissection. Not burping out viscoelastic, doing aggressive hydro without decompression causes capsular block syndrome. The chamber shallows, causing the iris to prolapse along with the viscoelastic. In eyes with risk of iris prolapse, burp out the viscoelastic. Do multi-quadrant hydro with small burst of fluid. If the iris starts moving towards the wound during hydrodissection, the first step is to gently press down on the lens with the cannula to remove the BSS trapped behind it. Lower the pressure gradient and this restores the iris to a normal position. If the iris prolapses, resist the urge to reposit the iris back through the same wound because it almost never works and this could make the entire situation worse. When you have iris prolapse at a later stage, it could be because you have used too much of viscoelastic. First, decompress the chamber, release some viscoelastic. Avoid going through the primary incision to reposit the iris. Go through a paracentesis to sweep the iris in. If the eye remains firm despite your release of viscoelastic, then it could be something from the posterior segment causing the positive pressure. With recurrent iris prolapse, iris loses its tone, becomes flaccid and comes on the way of insertion of phacoprobe. One point to bear in mind is that iris goes where the fluid flows. When you come out of the anterior chamber in foot pedal position 1, it brings a flaccid iris along with fluid flow. If the pupil size is inadequate or the iris is very atonic and likely to prolapse again, I like to use iris hooks, one directly under the wound. If I decide to continue with phaco, I take few precautions. Inject cohesive viscoelastic over sub-incisional iris. Enter the anterior chamber with irrigation off and then step on to foot pedal position 1. Consider lowering the bottle height, decreasing the flow and vacuum of the phaco machine and do slow motion phacoemulsification. Come out with irrigation off. Even a floppy iris will not prolapse if the fluid is not flowing out of the eye. Avoid wound-assisted IOL insertion technique. Inject cohesive viscoelastic over subincisional iris and then implant the intraocular lens. I stop the irrigation and let the eye soften slightly before I exit the eye. Stromal hydration raises the intraocular pressure and recreates a pressure gradient across the wound. The goal is therefore to hydrate the stroma without filling the eye. Hydrate all the side ports and the main wound, and then I fill the anterior chamber with balanced salt solution. Whenever possible, prevention is the key. Be cautious in high risk eye, observe subtle signs of IFS, create slightly longer wound, avoid overfilling the anterior chamber with viscoelastic. Remove viscoelastic before hydrodissection. Decompress the anterior chamber and then reposit the iris. Go in and out of the eye with irrigation off. Do slow motion phacoemulsification and lower your parameters. Support the iris mechanically with iris hook whenever necessary. Of course, a careful surgical technique will help to minimize the likelihood of damaging the iris. Thank you.
Wonderful tip, Kamal. Very useful and something which all of us would remember when we're operating these cases. I'm going to ask one question and I would ask the expert panel to ask the rest. Can you explain the mechanism of why we use atropine eye ointment? Can you explain the mechanism why we use iris hooks and how Helon would help in these kind of eyes? Can you explain?
Yes, ma'am. The basic pathology in IFS is the use of alpha-1 blockers causes irreversible blockade of the receptors in the iris dilator muscles, and this causes the muscle atrophy and the loss of tone of the dilator muscles. Preoperative atropine is going to block the sphincter muscles, and this is going to contract the intraoperative meiosis, and intracameral atropine is going to increase the tone of the dilator muscles to an extent, And hooks and hyalon is going to hold back the sphincter, iris sphincter, away from the area of phacoemulsification, and is going to tamponate the movement of the peripheral iris tissue. Pupil expansion devices works 100% of the time in these cases. All these things can be used in conjunction.
I think it was a fantastic presentation, Chitra. Excellent presentation. Congratulations,
I
Tamil
don't know if you're hiding Tamil. Such a smart girl she is. I don't know why she.
I know. Excellent presentation.
Thank you, ma'am.
Yeah.
My network was unstable. That's why I'm not switching on the video. Sorry.
No problem. Yeah, Chitra, can I add something?
Yes, ma'am.
Wonderful presentation, Tamilarasi. Really fantastic. You got all the points to tackle an IFIS or an iris prolapse intraoperatively, like a longer wound, everything you have done. But what I would suggest is you have clearly mentioned go in foot position 0, come out in foot position 0. That is one thing. What I do is whenever there is an iris prolapse, when I see that, I just put some viscoat at the level of the in the main incisional round, underneath the wound. So just put some viscoat there. That will push the iris back. Then you can inject, if you want, through the side port, you can inject some hyalon. Please, for heaven's sake, when you see an iris prolapse, don't use HPMC, because HPMC is going to make the iris more floppy, and more iris will start coming out of the eye. So that's one thing. Second thing is, whenever you see, whenever I see a pupil, a patient is on alpha blocker or tansulosine, something like that, or Urimax, my cutoff level is about 6 millimeter. My 6 millimeter, if anything's less than 6 millimeter, I straight away in the beginning of the case itself, I put iris hooks or Mulligan ring or BX ring and go ahead with the case. And David Chang taught me this: put a sub-incisional iris hook, and that works wonderfully well for this IFIS patients.
Anybody else? Dr. Maipal, Dr. Ram, anything to add?
I think Rohit should give his tip of the side port, because I have found it very, very useful. That's very, very important, I suppose, for IFIS cases.
Yes,
I think the basic concept which we have to realize, Dr. She has excellently said. I think what we have to work around is that the dilator muscle is atrophic. So when it is atrophic, there is a predisposition of the iris to billow. And that happens if there is an excess of fluid to the posterior aspect of iris. So the basic concept in the technique is that we should have a stable anterior chamber. And this stable anterior chamber, there is a study done by David Chang in which he did 32 cases of IFIS in which he used Mulligan ring and everything. He found, no doubt, the pupil was maintained to that extent, but there was IFIS in 28 out of the 33 patients. So no doubt your iris hooks or Mulligan ring helps, but then you have to realize the most important aspect of the whole story is technique, like long tunnel, capsular axis size smaller, all these things which she has said. Side port is something which is always, ignored. When we are having an unstable iris side port, what is happening is that there is turbulence around the side port incision. And whenever there is turbulence around the side port incision, there is a touch of the iris around the side port incision, which causes, the pupil to start constricting and IFIS is propagated. So if we make a calibrated side port incision, by all means, if we are using the techniques which have already been told, the side port doesn't become the site for initiation of IFIS. So side port calibration maintains a deep chamber, and it doesn't allow the fluid access to posterior aspect of iris by not having an ignored part of your, surgical field of unstable anterior chamber, which should never be the side port incision. So in short, side port incision keeps the chamber deep, and it doesn't allow access of fluid to the posterior aspect of iris.
Before we go on to the next case, I'm sure none of us tell our patients to stop Urimax now that we know.
No, please don't stop Urimax. Can produce urinary retention on the table.
And don't have time for humor here. And atropine eye ointment would you use How many days before would you all want to use?
Which one?
3 days.
Eye ointment for these patients.
I don't use.
Or we use it 3 days before.
2 to 3 days before.
Definitely helps. Yes.
Just a couple of points, Chitra. I mean, if I might, I mean, in the sense that, you know, great presentation, Tamil, though most of these videos look like mine. So messy.
Sir, thank you, sir.
All her videos. She
So,
has nothing to do.
You know, I was just telling that they are difficult cases. I mean, the points I wanted to make was that, you know, if you're suspecting there's bound to be a floppy iris, I think making a slightly anterior incision, at least 2 millimeter long, would be a good idea. And what we have to realize is that it's not the iris prolapse which causes the iris damage, but it's the iris reposition which causes the damage. So there's always an immediate tendency. I also do it quite often to go through the main incision itself. But as you very rightly said, going through the side port and then putting the iris back is most important. And this is one of the few situations I feel more than viscoat or anything else, I feel a small blob of Helon helps, because that really pushes the the flaccid iris a little down and gives you the space to introduce your phaco tip inside. And this again, sometimes you find that the surgery you're closed up, but then the first post-operative day, you find a tag of iris stuck onto the main incision or the side ports. It's one of the few places where, again, I use an air bubble to reform the anterior chamber and even suture up the main incision, because that ensures that even in the post-operative period, the incision is quite secure and you have a form chamber right through.
Anagha, can we go on to our next speaker? Thank you very much, Tamil.
Very nice.
Thank you.
So our next speaker is Dr. Vidushi Sharma, Director of Suvi Eye Hospital, Kota. She's a brilliant and versatile surgeon. Over to you, ma'am.
Vidushi, you have to unmute, I think, yourself. We can't hear you.
Unmute yourself, Vidushi.
Okay, so can you hear me now?
Yeah.
Yeah.
Yeah, okay. So this is my video. I'll be speaking on phacoemulsification in small pupil, and thank you very much, Dr. Chitra ma'am, for giving me the opportunity. So as we all know, small pupil phacoemulsification is difficult, leads to increased incidence of all sorts of complications that can occur during phacoemulsification. As you can see here, this is a small pupil. So right from capsular rhexis, everything is difficult. You have to perform the rhexis exactly at the margin of the pupil, and the chances of having zonular stress, etc., they all increase. And these kind of cases are common where there has been, lots of therapy going on. And as was emphasized in the last video, floppy iris is one of the commonest causes these days, where you have this kind of a small pupil, or even if it is not small to begin with, it becomes progressively small during the surgery, and then it's like virtually impossible to perform surgery here. So there are different techniques. One of them is your use of viscomydriasis. And out of all the cohesive, adaptive, viscoadaptive, viscoelastics that we have, Helon 5 is supposed to be the best. And the best thing about these things is that even if it is an unplanned small pupil, which we didn't expect in the beginning, you can keep injecting, and the pupil dilates because of the mechanical dilatation. And as it was mentioned before, the Helon 5 also tamponades the peripheral iris. So it helps with the floppy iris as well. And you have to be very slow and keep the bottle height low so that you don't keep washing out all that Helon 5, because as the Helon 5 is washed out, the pupil becomes smaller again. But you can just re-inject the Helon 5 and again the pupil will dilate. And then the most important thing is, in all these cases, we have to remove that Helon 5 from under the IOL using the twin compartment technique, or rock and roll. And the most commonly used nowadays is the Malugian ring, and all the different kind of rings that are available. We also have the Bhattacharjee ring from India. But still the Malugian ring is the most commonly used, and it comes in two different sizes, 6.25 and 7 millimeters comes. And the advantage of the Malugian ring is that you have a uniform expansion, and the pupillary margin is also protected because of the ring. So all the pupillary border is protected. So you have to inject it inside the anterior chamber, and first the 3 scrolls they normally go into the catch hold of the pupillary margin itself, and it is little difficult to adjust the subincisional the scroll. And the important thing is that while removing, we have to be very careful because during the surgery, the iris becomes a little edematous. So it is difficult to remove these scrolls because the iris becomes thicker. And at that time, there can be an iris tear. So we have to very carefully disengage all the 3 scrolls and take the Malyogen ring out into the anterior chamber after disengaging all the 4 scrolls. And then we engage one of the scrolls in the injector and then bring it out through the same incision. So the rings are the most commonly used now, and they are very useful for floppy iris cases also. Iris retractors were used more commonly before the advent of the various rings, but they are still commonly used. Various studies have been published and they have shown that the operative time is reduced significantly with the use of Malyogen rings, especially when you have younger surgeons. And this is obvious because for the iris hooks, you have to make 4 additional paracentesis incisions, and that takes time. But if the rhomboid configuration gives a very good exposure inferiorly where most of our phaco movements are taking place, and we can do the phacoemulsification very comfortably because of the configuration of this rhomboid. The only thing is that the subincisional iris hook tends to slip off, so we have to be careful that we don't rotate the globe, because as you rotate the globe with the phaco or the other instruments, it tends to come out. Now, these quick solutions in the OT are very important because all of these are different devices, but now the pharma companies are coming up with many different solutions which help in intraoperative dilatation of the pupil. And like this is the initial video we saw by NTOD for Phenocaine Plus. So these kind of things are now available, which are very useful for enlarging the pupil during the surgery itself. Epi-sugarcane is something that we have to make ourselves, which is a solution of 9 cc of BSS plus and lidocaine as well as epinephrine. And preservative-free, a combination of epinephrine and lidocaine provides a sort of a synergistic effect and achieves greater dilatation rather than using epinephrine alone. So now the pharmaceutical companies have come up with these ready-made solutions like Phenocaine Plus, etc., which can be very helpful if we encounter a small pupil during the surgery. So thank you so much for the patient hearing.
Thanks a lot, Dr. Vidushi. We will bring up the discussion of your thing after Saumil also present, because his case is also a small pupil. So Saumil, could you show your video and then we could take all the questions. We have with us Dr. Saumil Kothari, who is a Deputy Director and Head of Refractive Surgery Department at the Bombay Eye Institute and Research Center. He is also a Director of the Fellowship Program there, and he has a very simple learning tip for all of us. Not simple, but a learning tip which the good surgeons can do it very well.
Thank you, ma'am. Can you see the screen?
Yes.
All right. So I'll just complement what Dr. Sharma was talking about with the use of the hooks and the rings. Sometimes we are faced with such a situation where we do have a small pupil on table because of some reason, and somehow if the rings or hooks are not available, or if you don't want to use it, we should not forget what before the hooks and the rings came out, what our teachers used to teach us about the simple basic mechanics and the phaco-dynamics of doing phacoemulsification in a small pupil without using any aid. So out here, you need to just stain the. I usually stain the capsule because I know that it's a challenging situation, anyways. And you try to perform the capsular access with direct visualization using a Couglin's hook, and on the other hand, and using a 26 gauge needle, or you can use your forceps as well. Use a good quality OVD to help stabilize the chamber before you do this. So this is the reason why we stain the capsule in a small pupil, because we want a maximum visualization in while performing the capsular access, which happens to be one of the most important steps in such a situation. Once you have done a good capsular access, in that case, you just do a gentle hydrodissection. Here you see that this pupil is quite small, but in the words of Dr. Abhay Vasavda himself, it says that the small pupil helps us to remain disciplined and remain in the center of the eye without going too much in the periphery. So yes, definitely you need to just sculpt the central portion of the nucleus itself, and the small pupil enables you to do so without any discomfort. You have to go deep. Remember that going deep is important out here, rather than just enlarging your trench lengthwise. And once you have adequate depth, you can have a good crack at the nucleus. You divide it into 2 heminuclei. Once rotation is achieved, then you go on further dividing the nucleus into further quadrants. And mind you that the parameters should be low. It should not be high flow rate parameters and high vacuum. It should be low flow rate parameters. It should be you need to have patience in all these situations, but definitely your patience will pay off. And again, I'm not talking about I'm not against the use of using Malgugan rings or hooks. It's just that I want to showcase that even without this aids, we can still go ahead having a good phacoemulsification just by using our phacodynamics, playing around with our parameters. You can achieve a good surgery even in such a small pupil. Remain in the center. You can see that my left hand, my probe, I'm a left-handed surgeon, remains mainly in the center, while the right hand, my other hand, the Sinskey hook basically does the main work, right? And once you have that, bimanual IA does definitely help as compared to a coaxial IA, because with the irrigation probe, you can just definitely just retract the iris out here, and under direct visualization, go ahead and do a good cortical aspiration. Again, nothing against coaxial, but in my hands, but the bimanual IA definitely helps in especially these situations. Once you have done a good IA, you insert a good OVD, inject your lens inside. Here you can see a hydro implantation of the lens, which because I'm used to this sort of a thing. And once I have this lens in place, I just go ahead, dip it in, and check that it's in the bag itself and not anywhere in the sulcus. And once that is there, well, we just go ahead with the OVD removal, and that the case is complete. So I invite your comments and suggestions. Thank you very much.
Wonderful videos, both Dr. Vidushi's and Saumil. Wonderful. Saumil, I'll ask you this question, and some of these questions are going to be similar to both of you. Would you tell us, using Kruglan's hook, sometimes that could itself irritate the iris and make the pupil more small? It's something I felt when I watched your case.
You're absolutely right, ma'am.
On that?
So my first preference is, of course, without touching the iris, if I can make the entire axis, even partly with the understanding that where my focal point of the axis is, where my propagating point is, well and good. But in case, especially for beginning surgeons, I would say that you better do your axis under direct visualization. By the retraction, that's also fine. Both these techniques are fine. My preference is, of course, not to touch the iris.
And I wanted to ask you and Dr. Vidushi, this phenocaine which is being used, do you think it has a role play with in IFS cases wherein would it be increasing the tone of the iris musculature? Your thoughts on that?
Yes, definitely, ma'am. I would invite Dr. Sharma to comment first, please.
Vidushi?
Please unmute yourself.
I was just saying that Kruglan hook technique will probably cause an even more floppy iris. So it can be used for other kinds of small pupils, but at least in a floppy iris, it should not be used because it tends to make the iris even more floppy and with the prostaglandin release and all that. But it can be used for where you have had chronic meiotic use or something like that. So other causes of small pupils. And I think the phenocaine plus does help. But only thing is that the rings are obviously better because they will protect the iris margin as well. And phenocaine plus will have effect only for a very short duration. But if you don't have anything, it is the easiest to use during surgery.
The other question I'm sure all of us would want to know, Saumil or Vidushi could answer, what is your threshold for different pupil expansion devices? What would you tell the attendees here, which to use when?
Yeah.
So
it depends. Hello, it depends is there any associated condition involved in it? If there is pseudoexfoliation or if there is any surgical pre-surgery which has been done, in those cases, I believe that one can use these pupil dilating aids early on, because in pseudo exfoliation and in those patients who have had who have had surgery done, and the other surgeries, glaucoma surgery done. So in these patients, we end up with a situation that we can have more damaging to the iris. So in these situations, even a 4.5 millimeter, 4 millimeter is sufficient for me to, use pupil dilating aids. One important thing in deciding the pupil dilating aids at times is, what the anterior chamber depth is. If the anterior chamber depth is less than maybe 1.5 or so, my preferred dilating aid in that case is an iris hook rather than a malignant ring, because malignant ring in these cases causes more damage to the endothelium because of the maneuvering which is continuing. Another important thing is that, which was previously being discussed, the role of adrenaline is very important in these IFIS patients. But as and how the time passes, there is atrophy of the muscle, and once the atrophy of the muscle is there, then the role of adrenaline decreases in patients who are on alpha antagonist drugs.
Anything extra you want to add, Soumil?
No, ma'am. I would just say that for a beginning surgeon, please use the technique which you're most comfortable with. Do use an aid like a hook or a ring, rather than just going ahead with the small pupil without the aid. But my video was just to say that phaco can work to your advantage. That's about it.
And one to you, Vidushi. This uniplanar and biplanar rings, like Malugian and BX, which would you choose when? Any, or the third panel could add to?
Yeah, can I answer?
Yeah.
Yeah.
Yes, yes.
No, both the presentations were very good. Vidushi and Soumil were very good. Only thing is, in small people, I want to give a clear take-home message. Be safe, then sorry. Okay, right in the beginning of the surgery, you decide what pupil expander you want to use and go ahead. And I will not take a chance, even after this experience of so many years, I will not take a chance of having a small pupil, because all the complications are related to small pupil. The stress on me is so much, and definitely the complication rate is more. So right in the beginning of the surgery, and if you know this pupil is going to come down on you, either use iris hooks or Maligan ring or BX. When to use what? That is a question which Chitra has asked. Chitra, before that, I wanted to ask you, this ARC webinar is for the left-handed surgeons?
Why?
A lot of left-handed surgeons are there today. So I was wondering whether all the left-handed surgeons you picked up. So if it's a very small pupil, pinpoint pupil, my preferred choice will be an iris hook. Though Suvan says you can do a pupil stretching and then go ahead and do a BX, but my preferred choice will be an iris hook for that matter. If a little dilating pupil, about 4 millimeter or something like that, then Maligan ring or BX ring or the iris hook does. I think if you want to use Maligan ring or BX ring, because you can put just one incision and get away with it, and that's my choice. So otherwise, I go in for iris hooks. Only thing is, when you're putting the iris hooks, please make sure that your incisions are not very big, not very small, and it is also in the posterior limbal, not in the corneal. If you put it in the cornea, the entire iris will come forward like a tent. Okay, so put it in the posterior limbal so there is an equal traction. And don't keep the iris hooks for too long a time. Don't have the traction for too long a time. And make sure that once you remove the nucleus, you don't require the pupil dilatation much. So at that time, you can remove or relax the iris hooks and loosen the iris hooks a little, so that you can get away with the sphincter tear in these patients.
All right. Also, you need to differentiate between an elastic pupil and a rigid pupil.
Yes.
It's an elastic pupil. If you first inject BSS before you do anything, and if the pupil dilates, then it's an elastic pupil. A BX works really well. If it's a rigid pupil, then probably a Malugan would work well. The advantage of the uniplanar, madam, when you asked about that, the BX being a uniplanar is advantageous, especially if you have a pupil which comes down later after you have done a CCC. Then using a uniplanar BX will ensure that the CCC is not trapped. If it's a Malugan, because it's a biplanar, it could
entrap the or iris retractor could entrap the CCC also. And in case of a shallow AC, I have used BX. It really works well.
Yeah.
Just one comment I want to make based on Mohan's last point that, once the nucleus is out, most of the surgery is over. I think most of us believe that dilatation is, etc., is necessary more for the nucleus emulsification. I'd like to emphasize that good visualization is equally important for intraocular lens implantation also. So
yeah, I understand. No,
and
what
for the cortical
what I meant, Ramurthy, what I meant was to just relax the iris hooks a little at that time.
I'm just saying that in case, especially if you're using a technique like sawmill without any dilators, in those cases, I would not like to do a wound-assisted implantation. I would like to make a slightly larger incision, have my cartilage mouth almost at the rhexis margin so that the leading haptic and half the optic goes inside. Because if it opens up in the anterior chamber or in the sulcus, it becomes extremely difficult to introduce the lens through a smaller pupil with a small rhexis. And also, again, if you are using plate haptic lenses, I stopped using them long back, but recently I've started using some trifocals which come in a plate haptic design. If you have a small pupil and a small rhexis, it's extremely difficult to introduce these lenses. So it's important that you ensure that right in the first go, at least half the lens is inside the rhexis, even if it means making a slightly larger incision, and then you just tuck the lens inside. Of course, all other points regarding nucleus management has already been made.
That can be removed at the end also. What difference it makes? Anyways, you can wait till the cortical eye and the lens implantation.
If I'm using a device, I would use it only, remove it only after implanting the lens.
Implanting the lens.
Remove it. We remove, just relax it. I said relax it.
Relax it, yeah. Or
yes.
actually, even in the beginning, we should not totally from limbus to limbus.
Absolutely.
It should be very loose.
Require that.
You don't really require such a large pupil.
Absolutely. But I would not do, I will tell you, I'm telling, being this webinar is an international webinar. So many delegates are there. I will not do a small pupil without iris. Yes,
absolutely.
I will not do.
Yes, agree.
I will not do.
And I think that should be the message sent across that
yes.
we should not take the risks. Right?
Can you go on to introducing the next speaker, Anagan?
Yes, ma'am. Our next speaker is Dr. Jayant Sarvate, sir. He is heading the Divya Drishti Lasers Private Limited. Over to you, sir.
Thank you. After hearing this discussion of a small pupil, I will be telling you the case of a complicated cataract in a seclusio pupillae. This is the uveitic 43-year-old female with a chronic uveitis, a complicated cataract with a occlusio pupillae, and a planned phacoemulsification has been planned. So in this case, as Dr. Rajan was saying, I right from the beginning decided that this will require iris hook rather than any other pupillary device, expanding device. The first challenge was the breaking the pupillary membrane. I was intending to use a micro scissor, but I was not sure whether there were any synecdoche, extensive synecdoche between the capsule and the iris. So I wanted to do a blunt spatula separation. A separation with the help of viscoelastic. I was partially successful, and after some time, nudging the membrane, I could have one opening, and after that I removed all the synechia in one quadrant. Then from the other side, I separated the iris from the anterior capsule. Now the second challenge was the pupillary expansion device. As I told you, in such cases, no other device I was thinking, because I wanted to do a stretch pupilloplasty with the help of these two pupillary expander iris hooks. I am doing this stretch pupilloplasty, and now I am introducing other iris hooks. Again, I am giving only a half of the stretch now, and after some time, when I know that I have not caught any capsule or any other tissue, I am stretching all the hooks And now I will be performing phacoemulsification in this dilated pupil. Here the capsule also is very inelastic, thick because of the chronic uveitis, but I could perform a good capsulorhexis. And after performing the capsulorhexis, the nucleus I wanted to separate properly by hydrodissection because I did not want to have more stress on the zonules while performing the phacoemulsification. Fortunately, I could do a good nucleus rotation all around, and then nucleus with a sharp chop or vertical chop and a direct chop technique. I did multiple pieces of this nucleus. Here again, a bigger opening of the pupil did help me in deciding the exact plane of action of removal of the nucleus. The capsule, aspiration of the cortex also had to be gentle because again I was not sure whether I would again damage the zonules while doing that. So I was very slow and meticulous in this. And after this, I implanted a foldable IOL, and now I removed these after implanting the IOL, not before, because I wanted to be sure that this IOL was in the bag. Now, whether to do a pupilloplasty in such situation, I decided against because she was under steroid cover, and that's why I deferred this choice at a later stage, and the patient could get a very good 6/18 vision unaided on the in the first 3 or 4 days. Thank you very much.
Thank you very much, Dr. Jain, for a wonderful surgical video. I would, one or two things before we are going to go on to the next session, which doesn't deal with iris hooks. For the sake of the audience, I think we should place the iris hooks first and then tighten it. It should not be that each is being placed and tightened and then we go on to the other, because that could cause a sphincter tear. That's one point. I do think there is a big role of the subincisional iris hook also, because there is sometimes the iris gets to so stretched between the two iris hooks placed, and it gets difficult to insert your phaco probe, especially in small eyes. And the other thing with Dr. Jain's case, I felt that I would go and try to release the synechiae by going underneath, but I wouldn't want to stretch the pupil at all, because in these complicated cataracts, there is excessive iris manipulation. You could have CME. So I would go straight to placing the iris hooks. I want the thoughts of the expert panel in this.
I think, Chitra, I would agree with you on that we can put the iris hooks there and also not stretch the pupil so much. But I think more importantly in these cases is the post-operatively, what are you going to give? Because post-operatively, again, the pupil is going to, if the primary pathology is not taken care of, uveitis, etc., then it will again come back to the same thing. So that I think is very important post-operative. I've seen a lot of cases where they have capsular phimosis and they come back, to their pre-operative seclusio-pupilly kind of a thing. So that needs to be prevented.
So I think in these cases, it is as important as in the case of IFIS to start the patients on pre-operative steroids.
Right.
They were on steroid, under steroid cover only this was done.
And operatively, I think NSAID as also steroids, as also cycloplegics.
Full dose of steroids were given. And another thing, I did my capsulorhexis in a bigger manner. I mean, almost 5.5 millimeter capsulorhexis, because I was expecting this capsular phimosis and other complications. And there was a very tough membrane. Actually, afterthought, I thought that I should have used a micro scissor to cut this membrane, but I was not sure whether it was touching the anterior capsule or not. That's why I did not use it, but I could have done that also.
Good.
In this case, you had to use devices, but then, sometimes you're quite pleasantly surprised in situations like this when you release the synechia and take away the membrane and fill in some high molecular weight viscoelastic, you get a nice big dilatation and no device is necessary. And as you rightly emphasized, I think in these cases, getting a big capsular excess is important because there's a great tendency for capsular contraction. And most of us
she did have a all-round synechia, posterior synechia, which I had to separate.
So there's no question of dealing with, doing a pupilloplasty in these cases, because less we handle the iris, the better. I would rather have a irregular pupil in these cases rather than do more maneuvers. And in these cases, I think it's also important to investigate about what really caused this, because, most of us cataract surgeons are able to deal with these cataracts, but then we also need to look at the primary pathology, because as was mentioned, unless we take care of that, sometimes you could end up with difficult post-operative situations.
This is a typical situation. For last 3 years, she has been investigated all the time, but without any result. And all the investigations were, they were uncommented. There was nothing we could point out. And there are so many such cases we come across.
Thanks a lot, Dr. Jayant. Anaga, can
I add one point, Chitra?
One small point, yes.
One small point. No, just nice video, Jayant. I just want to say, in seclusio pupillae, it's not enough that you release only the synechia in the pupillary margin. You need to go with the rod all the way underneath the iris, all the way to the root of the iris. You did that?
Yeah.
I didn't see that. I'm sorry.
No, I did go all round 360 degrees from the slit which I made.
Sorry, I had gone to the restroom at that time. Sorry.
One point which I would like to add is that we should know that these patients are one of the few conditions which have predisposition to post-operative hypotonia. So seclusio pupil is one, IOP 6 millimeter or less is another, phacodonosis. So UBM should also be done in these patients to really find out whether the choroid is diffusely thickened or not. So these are a few things which should also be borne in mind.
Actually, we had done a B scan and not UBM, but the B scan did not show any posterior pathology. That was done. All the investigations were done before taking her for cataract. She had perfectly.
Gives enough information. You are right, Dr. Jain. Dr. Anaga, can you introduce the next?
So our next speaker is Dr. Cyrus Mehta, young dynamic surgeon and surgical chief of the International Eye Center. And over to you, Dr. Cyrus.
Hi, everyone. It's been a wonderful day for me today. I've learned a lot. I've never seen an expulsive hemorrhage in phaco, but nice to meet people who have seen one. Okay, so this is a bit of a unique situation. We bought this Catalyst system about 4 years ago. In the beginning, we were playing with it and trying to figure it out. And the application specialist knew even less than us. And it's been a kind of learning experience. So this is what happened right in the beginning. So a patient like this presents, we thought it would be a great idea to fix this with femto. But the femto, instead of doing a rhexis, has made some odd puncture marks like that. So we were left doing a regular capsular rhexis with a forceps. And in an extreme subluxation like this, it's always a little challenging. And the rhexis started to run away, you can see that. So I started pulling it in the opposite direction to get it back in. And somehow I managed to complete the rhexis by tearing a few zonules, but I had a very, very thin rim. So this rim is so thin, I cannot put capsular hooks anymore. So even though I do have a rhexis, now my only option is to use an anchor. So an anchor is basically a PMMA device with 2 legs. This was invented by this guy in Israel, Ehud Assia. They've come out with version 2, which is 3-dimensional now. This was a single-dimensional anchor from 4 years ago. And this was a free sample that he had given me. So I fished it out, and you tie it to a 9-0 or a 10-0 Prolene suture with a straight needle and railroad the suture out of the eye. So this is a very straightforward procedure. It's very simple. Just go about 2 millimeters behind the limbus and just railroad with a 26 number needle, railroad the straight Prolene needle out of the eye. So now you've got the anchor inside the eye sitting on top of the anterior capsule with the human lens still there, attached by a suture which is going out at 6 o'clock. So this was not really a cataract, it was more like clear lens aspiration. So I'm just using a bimanual eye, which gives me better control. I don't have a unimanual anymore, so it's not much of a question of do I like a coaxial or bimanual. I don't have a coaxial, so it's always been bimanual since I started doing phaco 20 years ago. So in goes the anchor. You can see you can trap the capsule in the legs of the anchor, and then you pass that same needle through half thickness of sclera. So one pass, and then you can make a second pass and just tie it and bury the knot. So you don't need the scleral flap or anything fancy there. That knot will not come out and will not irritate. This patient comes for follow-up. He's a young boy, comes for follow-up. Now it's been 3 years, everything seems to be okay. So you've created a capsular bag now, which is rather well centered. And in goes the IOL. Open it on top of a iris repositor so it doesn't suddenly spring open, because if you dislodge the device from the capsular margin, the whole capsule will just flop away and then you will be stuck. So you can see that's a traction line there. The lens is in the bag, and that's the end of the procedure. We did some limited anterior vitrectomy after tricot, etc. All that's been edited out. That's just a little bit that you saw at the end. So that's the end of the surgery. So even though basically take-home messages, if you have a very thin capsular rim and you still want to retain the capsule, you just don't want to do a scleral fixator or glued IO and things like that, you can still manage with the anchor type of device. Thank you.
Thank you, Dr. Cyrus.
Wonderful.
I'm sure it goes without saying that if there is a rexus tear, you can't be using this, right?
No, of course not. So this is an intact capsule, but with a very, very small capsular rim.
Cyrus, I just wanted to know, what was the diagnosis? Was it ectopia lentis or was it a...
This was an ectopia lentis, ma'am. It was bilateral. We did the same thing in the other eye as well.
Only thing is that ectopia lentis, this zonular problem tends to be progressive. So over a period of time, again, you would have to closely watch that zonules do not become progressively weak. And that is why in these cases, a glued IOL would also be a
we did the same procedure in the other eye, and this was a school-going child, 8th, 9th standard, and he got hit on the eye, and he said, suddenly I can't see, and he came back, and the capsule had fallen off the anchor in the other eye, and the lens had fallen into the posterior chamber. So out came the lens, and then we did a glued IOL in the second eye. But this one is still staying there quite well.
So Cyrus, I would agree with Amrita that the procedure of choice should be a scleral fixation, whatever way you want to, because here you are just making a connection at a limited point, and this is a progressive thing which would go all over. And the has a long way to go, and the dislocation or total or a partial subluxation can also happen where the tilt can be there. So you need to disregard the capsule, sacrifice it, and go in for any Yamane or whatever glued IOL, whatever technique you want. That would be the best for such a case. That
right,
is, I think from the femto, what you did or didn't do was that you, when you get the image at that particular time, one was that you should have done it on capsular center rather than, I think it was still seems to be on pupil center. That's why it was such a decentered capsulotomy. The second thing is that you never get the OCT image coming on its own. The planes of the nucleus, the anterior and the posterior, do not come out well. So you have to actually work on the bubbles to bring it and align it. So that is why you didn't get an adequate round cut, and it was because it seems to have been off focus from the anterior capsule. That was the reason why you got these skip areas to such a large extent.
Apart from the points that was mentioned, sometimes if the lens is quite subluxated, in spite of all the adjustments, you don't get a very uniform rexes with even in the femtosecond. But of course, this kind of large skip areas I have not seen, and even in this subluxated cases I have used. The question to you, Cyrus, is that, I mean, this seems to be, I have heard about this device, but I don't think many of us have much experience with this. Is it better than a Hamid segment simply because it seems to have 2 points of anchor? And secondly, very often we use an endocapsular ring also along with in these situations. Of course, I agree that in these extreme subluxations, maybe going on to a scleral fixation would be a good idea. But if you have to use it, is it possible to, is there space enough for an endocapsular ring also to be introduced along with this?
We would have to use it.
Yeah, the new version of the ring has got 3 dimensions. I've seen it. I haven't got one, but it's 3 dimensions like this. So it's much easier to engage and probably easier than an emerge segment because it won't slip out. It's like a paper clip, like what Dr. Susan Jacob had shown in many of her videos. It's that kind of a device. So it engages very nicely into the bag. I think, of course, all these things are expensive and not available. So it's good to make one video and show everyone. And then after that, we go back to the emerge segment.
Also in this ectopia lentis, if I am planning to do a glue dial or scleral fixated IOL, then rather than making a single capsulorhexis, you can make 2 stab incisions on the capsule itself and do a intralenticular aspiration so that this thing doesn't drop down. And especially in extreme ectopia lentis, with the 2 irrigation as well as aspiration port, and if it's a child, you just need to aspirate. You get it to the center because you can always put it to the center and do an intralenticular aspiration followed by the vitrector. You eat away the capsule and then do a glue dial.
Paucity of time, I think we go on. Yeah. We have 3 more speakers.
One last one. If you have to preserve the bag, as Dr. Mahipal was discussing, if we have to preserve the bag fixation should be done. It should be a double bag fixation at 180 degrees apart. Dr. Cyrus, I would have gone in for a double fixation because it's a progressive one to if we think of preserving the bag.
So actually, there is no great sense in preserving the bag because then it's a young child. You will have PCO and you. So actually, in such a huge subluxation, apart from showing a great video during these sessions, I would personally not be interested in preserving the bag because you.
Yeah, this was basically an OPL video, so.
Give it out to me. Mahipal, I just want to, because the tilt was so much.
Yeah.
That is the reason why the femto was not able to identify the capsule.
You get a good focus on that because the line is very difficult to get a good focus. And if you just press the button without focusing, that's a problem.
Yes.
Thank you. We go on to our next speaker, Dr. Kishore Pahuja, who is the director of Niramaya Hospital and chief of Ophthalm department. He's going to teach us some more learning, something quite interesting too. On to you, doctor. Can you start? Unmute. You're muted, Dr. Kishore. Can you unmute yourself? Dr. Kishore, you have to unmute yourself. Dr. Sunil, Mr. Sunil, can you unmute? Yes.
Please, that's just it.
Yeah, I mean, is my screen visible now?
Yes.
Okay, so I believe that probably poster capsule is my friend. Thanks, Dr. Chitra, for making me part of your wonderful session. PCO is the most common complication of an cataract surgery, and incidence is known to be almost about 36 to 97% of patients in about 2 to 4 years of an cataract surgery. And we all know the risk factors, age, diabetes, uveitis, trauma. So what are the modifiable surgical factors that we have is an CCC, heterodissection, what we call as an cortical cleavage heterodissection, and of course, IOL factors and a posterior capsule polishing. So what I'm going to talk today is basically as a posterior capsule polishing. So I'll just share my video. Yeah, I mean, this is my way of doing an cataract. So I do an capsular marking. I mean, for an capsular access for all my patients. So this is just a show like this. So this is my case that I'm just present is that it is a white matte cataract where you can't see anything. To have because it's an entomycin, so what I do is I just make a one port within a 26 gauge needle, go and aspirate the whole of a fluid that is there, just to reduce the intralenticular pressure. And once you do that, and after that, it becomes very easy to do on a capsular axis. This is how you go within a capsular axis. You can go within a capsule, you can go within a forceps. This is within the left hand, I'm just pulling within a forceps. Then you can change your hands and do within a right hand. So whatever, but then the advantage of a marking is that where you have I mean, you have a circular capsular axis, and also it guide you that you are not going away and the decentered with that. This is how you just do a hydrodissection. Just go lift the capsule and go that, then it becomes a simple cataract that you do it. What's more important that I'm just going to talk today is the once you remove a cataract, then you see some little white plaque over there. So then you think of it whether it can just go with only within a hydrojet pressure, which you can do that and then clean it off, which usually in most of the cases it happens. So here you see that it's there, and I'm just trying to do within a bimanual aspiration. You go within a low vacuum and remove everything which is just in the periphery. But then try to clean it everywhere, but still I feel that I was not able to remove it. So what I did is push on a visco, increase in a magnification, and then hold that within a micro forceps. This is, I mean, you learn from my retina colleagues that, I mean, how you do an ILM peel. So you hold that forceps, I mean, hold that capsule within a forceps and then just pull it off. It just goes like on a capsular axis. So this is within a right part of it, and this is within a left part of it. Hold it, and then you just pull it all this, and then this is how you I mean, because today we are talking about in a premium oil practice, you're doing in a toric multifocals and all that, so you want to reduce the posterior capsular opacification in an immediate post-op period. And you see that even in thin capsules, thin plaques that you have it, you just hold it, pull it off, and it just comes very easily. This is here, you just keep on pulling it, and then it's just like you feel that you're doing in a capsular axis. But mind is just only the plaque which is just coming off from there. And then your central part becomes very clear, and then you can do that. And sometimes it's when you do a practice, so what you do is you have a sandblasted IA. So with that, what I do is I just probably do a capsular polishing. So, and with that, a lot of things goes out. I mean, if you feel that still there is some thin plaques which are going to go. This was probably in a multifocal patient that I wanted to do it, and I didn't want to have a central piece into that. So I just remove that with that. And also then you go within a sandblasted cannula and then just polish that and polish that capsule. So I always believe that if you respect the poster capsule, I mean, it always becomes your friend. Thank you very much, and I'm just here for the questions now.
Thank you, Dr. Pahuja. That was nice videos which you saw. But I suppose just for the audience, like you take your bevel in when you're aspirating fluid, we should tell that the bevel should be down, because the bevel is up, it can inadvertently catch the capsule. I have a question for Dr. Ramurthy and one question for Mahipal. Dr. Ramurthy, when are the cases when you would ask for an anterior lens capsule polishing? And to Mahipal, when would you avoid a posterior capsular polishing?
You should have told me before about this.
Of course, I mean the posterior polar cataracts or in a posterior dehiscence is a contraindication for an polishing. But otherwise, I mean, if you feel, I mean, there's the plaques that you see it's always better to do a polishing, or you can just remove that plaques.
I think to answer Chitra's question about anterior rim polishing, I don't think it in any way contributes to preventing PCO. But in cases of pediatric cataracts, in cases of pseudo-exfoliation, subluxated lenses, and in case you end up with a smaller rexis because of other reasons that you're not able to enlarge it, it's a good idea to polish the rim of the capsule to lessen the chances of capsular phimosis. In these situations, I will actually nick the edges of the capsule so that, I mean, the chance of the capsular phimosis is reduced. And beautiful videos, Dr. Pahuja just showed that in these plaques, there's always a plane of cleavage which you can identify and take off. Just to point for the audience is that, please remember that PCO occurs because of the metaplasia and migration of the equatorial cells. It's never because of a plaque which is paracentral. So just because Dr. Pahuja showed you so beautifully in his hands, if there is a paracentral plaque and in case it's not coming off easily, don't go ahead and try to take it off and break the capsule because it may not harm the patient in any way at all. So unless it's in the visual axis, maybe it's not necessary to deal with these cases. And if you're not confident enough, a YAG laser can always be done a little later. But if you're capable of doing
this is the whole of the idea is because they both, I mean, if you see they were in a central, and second idea to remove that is because actually you have a gap in between the capsule and the poster capsule and the lens. So when there is more of an space or some occupying, then the migration becomes much faster, and then you get more of an poster capsule opacification. So whatever you can remove is always better, and whatever you can't remove it, if there's a risk, it's always better to leave it.
Dr. Mahipal, would you have anything to add?
I think part of your question about the posterior capsule was answered by Dr. Bouquet and part by Dr. Ram. So I'll just to re-emphasize, whenever you are suspecting some kind of weakness in the posterior capsule, that's the time that you need to avoid.
Not able to hear you, Mahipal.
Not able to hear you.
Sorry, so can you hear me now?
Yes, yes.
Okay, so whenever you are suspecting any form of posterior capsular weakness, like whether it be a posterior polar or there is some doubtful history of trauma or something like that, where you can disturb the vitreous, it is better not to try any heroics. In case you have a extensively fused kind of a posterior plaque, which separation plane cannot be done under those circumstances where you can cause a rent. Under those circumstances, it's better to go back and do a YAG capsulotomy at that particular time. So the importance is to assess the integrity and the whether there is any weakness in the posterior capsule. That's when I'm going to not do a posterior capsular polishing. Apart from
yeah, you continue. Sorry.
Apart from that, what Ram said, I agree with that completely, that it's the lens equatorial cells which kind of come forward and cause the this thing. It's not really, so it's the fibrillar material, the posterior plaques or anything that's sticking onto the posterior capsule, that's what needs to be taken out. Apart from that, there is nothing much that you have any posterior epithelial cells on the posterior capsule that need to be taken out. So just...
No, I had a doubt whether in a silicone oil filled eyes, they have a tendency for a PC plaque to happen in these eyes. Would you go ahead and do a PC polishing in these eyes because these posterior capsules could be thinner? There could have been an lens touch.
No.
They don't normally have thin capsules. They are parchment-like capsules, which are very difficult to do that. And normally, whenever there is a silicone-filled eye, we normally would take out the oil from this
and then
by doing a primary posterior or a posterior approach. So it's very, very unlikely that you are going to do a cataract with silicone oil still being in the eye. So either the retina surgeon has removed it before, or we do it as a single sitting by doing a primary posterior capsule.
Yeah, because it becomes very difficult. Oil bulges so up and then it becomes difficult to do in a cataract surgery.
Oil keeps on coming from the side, from the zonules that it keeps on coming. So it's unlikely that we will be doing a case without removing this thing.
Can I add one point?
Yes.
No, the beautiful videos we showed. I just want, because this plaquectomy is what I describe this technique, wherein you go bimanual, just like you remove a ERM from the retina, similar from the macula. So the bimanually, you just hold the plaque at the base of the plaque with a small, with a micro forceps or something like that, and then remove it with the capsulorhexis forceps. So it works wonderfully well, because what happens is when you do bimanual, you create a space between the plaque and the posterior capsule. When you do unimanual, what happens is you try to pull the posterior capsule along with that. When you have bimanual, you keep that plaque on the surface of the posterior capsule, and the posterior capsule doesn't come forward. When the posterior capsule comes forward, there's a danger of the posterior capsule getting injured. So that is, I think, reason why I thought I will just mention this technique.
What about in high myopes? Is there any specific thing that you would do? Formation of PCO in high myopes.
No. I mean, I say
polishing definitely in these eyes, I'm sure, because
you don't want
yes,
PCO,
for having a PCO.
Want to avoid a YAG.
Yeah, I mean, for any patients, you want to avoid an PCO in an immediate post-operative period, because when you do in a multifocal patients and then your contrast is not good, so it's always better to have that. I mean, I just wait for about 3 to 6 months to do if I have to do an YAG capsulotomy.
3 to 6 months.
No, sometimes
minimum period would anyone wait?
Yeah, 3 months.
Yeah, 3 months is that, I mean, the earliest I would prefer to do in 3 months. I will not do it before 3 months because anyway, I mean, if you do that, there is a chance of getting a cystoid macular edema also. So it's better to wait for 3 months, let everything settle down, all inflammation, mild inflammation, whatever is happening. And then after that, if you do it, it's always better.
I think it makes sense to do PC polishing in a high myope and not do it 3 months opening and all that.
No, I'm just talking about the capsulotomy in a multifocal patient, immediate post-op, whether it's myopic or it's an emmetropic patient.
One message I want to give Chitra is that if there are dense plaques, please don't leave it, because very difficult to YAG these plaques.
Yes.
You have to use very high energy, and you can have pitting of the lens, you can have problem of retina. So all these problems can occur. CME. Yes. So if you have dense plaques, try to remove it on the table.
As far as you can remove it, it's remove it. And then if you can't touch it, you have to take care of a capsule also.
And the beautiful technique shown by Kishore.
Wonderful.
One point, if you don't see a cleavage plane, then you can use a cystotome, and by not bending it more than say 30 or 40 degree, and with that you can lift it and create a cleavage plane.
Yes.
So that can also be done.
Sometimes it's even necessary to make a posterior capsular excess, which encompasses the central plaque. I mean, which goes beyond the extent of the plaque. I would do it only if it's central.
It's not necessary, Ramurthy. That is, see, if you have a plaque, there is a definite plane between the plaque and the posterior capsule. You just have to put some nice cohesive viscoelastic and separate that plane there and identify that plane and start from that, similar to what you are doing for the epiretinal membrane. I'm sure you are also a retina guy. I'm also a retina guy. Just go back 20 years back and remember your retina, that's all.
No more. There are some fibrotic plaques and there are some plaques which have more of material there. Those can be lifted up. Sometimes the capsule itself is fibrotic. In these cases,
that's right. Yeah.
So
you can't get any cleavage in that. The tip is that when you do a hydrodissection, within a hydrodissection, if you can see some cleavage into that, then you can do that. But even within a hydrojet, if you can't see any cleavage, it's better not to do that, because those are the capsule. I mean, it's a capsular. What is that? It's actually capsular thickening, not any plaque on that.
Anaga, can you introduce the next speaker?
Yes, ma'am. So Dr. Sheetal Mahuvekar is our next speaker. She's the Senior Consultant of Cataract, Cornea and Refractive Services at the Retina Foundation in Ahmedabad. Can you please share your screen?
Is my screen visible?
Yes.
Yeah.
I am not able. Okay. Yes. So thank you so much, Chitra ma'am. So my case is very similar to what Dr. Amit has shown. Basically, it's a PPC case. So recently what I've started doing is, after ruling out the retinal and glaucoma pathology, I started giving them the IOL options of monofocal as well as multifocal. Along with that, every PPC case, we do tell them about maybe the need of anterior vitrectomy, maybe the need of retinal surgery, or the retina surgeon getting involved. So after explaining everything and telling them that the change of the IOL, the plan of the IOL can change on table. So I started my surgery pretty well doing the Rexis, and I generally plan hydrodelineation in the PPC case. So when I did this hydrodelineation, I thought that delineation did not happen. I wasn't very sure whether that was a hydrodissection or delineation, but as you can see, the iris started coming out through the main wound. Now the mistake I made out here is started going through my main wound again, and I repeated delineation because I thought it was an incomplete delineation. what I noticed, and which is not very well visible in this video, is the AC started getting very, very shallow, and there was an upthrust of the nucleus. Iris started coming out from the main wound. I tried putting the iris initially through the main wound, which you should not do it, as Dr. Tamil, I think, has very nicely said that one should not go through the main wound because it keeps coming out, and sometimes you can cause holes if you start going through the same wound. So eventually I realized that, okay, that's not which is working, and I went through the side port and kind of reposited my iris back. Now there was hardly any space for me to go and do anything in this particular case because AC was extremely shallow. As it was a plain case of PPC, there was no nuclear sclerosis part. What I decided in this particular case is, let's just reposit the iris properly and go ahead with the irrigation aspiration instead of putting the thick probe inside the AC where there's hardly any space for me to work on it. So I continued with irrigation aspiration, and this I'm just showing it in a fast forward. As you can see it, when I was doing the irrigation aspiration, I saw this particular rent which was there, a nice posterior capsular dehiscence was there. Now at this point in time, I am not very sure whether it caused because of my either hydrodelineation which got converted into dissection, or it was like pre-existing dehiscence. So before taking out the cortex, what I generally prefer it was a big rent. I decided to go ahead with the pars plana approach of anterior vitrectomy, which is my general approach now, where I go only by one port and this irrigation is through the side port. This is a video thanks to Dr. Sambaresh Shail. I've taken it just to show what happens when you do the anterior vitrectomy through the limbal approach and what happens through the pars plana approach. Anterior vitrectomy through the limbal approach, basically the vitreous is just coming out, so it can increase your rent, whatever is there. But if you do it through the pars plana, the rent remains almost the same size and you cause less damage, I think, to the capsule in general. So after doing the anterior vitrectomy, I decided to go ahead with my irrigation aspiration. At some point in time, I thought there was one strand. The ideal thing to do out here is putting tricot and do your anterior vitrectomy. Somehow, I did not do it in this particular case, and I do not, to be very frank, every time put the tricot because sometimes I don't like that view which disturbs, and a lot of tricot goes into the vitreous and sometimes can cause glaucoma later on. So, but looking at this particular rent, I decided that, okay, we had spoken about and we had discussed about the multifocal IOL, and because that rent was central, I decided to put in the multifocal lens and go ahead with my plan. As I think Dr. Ramamurthy had said that after every case where there is a kind of iris prolapse or where iris is like little floppy, I like to put the air at the end of the surgery so the iris actually nicely sits back. So this is a picture which is 7-day post-op, and I hope that it remains like this. Although this is the first time I have done something like this where there's a rent in the PPC and I went ahead and did my multifocal IOL. Generally, what I do is I will go ahead with my multi-piece IOL. So at this point in time, I would like to ask the panelists, A, should we go ahead with multifocal? B, because this rent was slightly bigger, I decided not to convert it into the posterior capsulotomy because at that point in time, I thought that if I convert it, it will become too big an opening and I may not be able to put my multifocal lens. So I would like to have some comments on this. Thank you so much.
Thank you very much, Sheetal, for your video. I just felt that I should, more for the attendees' sake, that we need not be so gaga about doing a pars plana vitrectomy in all cases because these are hypertonous eyes and placing a trocar might be a challenge for an anterior segment surgeon. I believe that if you have two snug fit side ports and if you're able to go and do vitrectomy behind the posterior capsule deep down, and one your infusion which is directed away from the vitreous cavity, why should you have a lot of vitreous loss and vitreous getting overhydrated? I think it could be just the limited vitrectomy which is needed. I wanted the thoughts of expert panel on this.
Want me to answer?
Yes.
Yeah, I think she did a wonderful job putting a trocar and cannula into the vitreous cavity and doing a pars plana anterior vitrectomy with an anterior chamber maintainer. That is the way to go. But the only thing is I would have used a diluted tricot, 1:4 diluted or 1:3 diluted, dilution that takes care of because unless you use tricot, you will not know whether your vitreous is completely removed or not. Vitreous is a colorless substance, and unless you have a very high-end microscope, it's very difficult to see the vitreous. So another thing is, I wouldn't have put a multifocal lens in this case. I would have put basically a multi-piece lens and in the sulcus and put it in the captured the lens in the bag, because this lens, the tear is a little large, and during the implantation, fortunately you were lucky. During the implantation, it didn't extend, but it could have done, and you could have seen next day sometimes the lens is on the retina. So that is what I would have done in this case. But what was the reason for the posterior capsule? Was it hydro rupture?
I really don't know. So that's what I said, that because my hydrodelineation was really not good in this case, although I thought that I went into the substance of the lens and did it. But if you remember, when I did the hydrodelineation, I did not see a ring, and I really did not see a good hydrodelineation. So I think instead of hydrodelineation, what happened, there was a hydrodissection. And that could be the cause instead of
it is probably an accidental hydrodissection, which has occurred, and probably that has caused the PC rent.
I think it was a hydrodissection, and that's why you get such this thing. The only thing I'll agree with Mohan is that I won't go in for a single piece lens, and I won't definitely not go in for a presbyopia correcting lens, because any amount of decentration which could be there could have a problem. And one more practical tip is that at least since the chances of wanting to of having a pre-existing rent, etc., are much higher, all our patients are counseled with a posterior polar cataract. Whether it's a TPA case, we ask for an approval for cataract plus anterior vitrectomy.
Yes, so that we do, sir.
We always write plus minus anterior vitrectomy, because it becomes very difficult for a patient to pay later. Because the point is that that's a different package which we have. So, and also we have all the lenses that are available are 3-piece, even if you have to go in for a glued IOL. So the preferred lens which a lot of surgeons have is MA60. Otherwise, we go in for a Technis 3-piece, and we have the single piece, and you can have. So the patient is counseled and a special consent is taken, because quite often this is the problem that can happen. And never ever believe just what the patient has given you or not given you a history. Always look at the other eye. At times when you have a hard cataract or something like that with a posterior polar, I still remember there was a patient who came, and I started doing my phaco without realizing. This was I think before 2004, because I remember it was in my Green Park Center. And within seconds, we did a hydro, and the whole thing went down, and I didn't know what to do. And at that time, I didn't have a retina support, so I sent it to Cyrus to take it out. And then on careful examination, he had a Kelman multiplex in the other eye, which we had missed. And the patient said exactly the similar thing had happened, that we had the nucleus had fallen down, but that history was never given to you. So looking at the other eye, specifically in patients in which you can't see the posterior aspect, is something very, very important if you are operating on the second eye, because often patients don't divulge this particular fact. And taking a pre-operative consent and a pre-operative, if you have different charges, if you have to do an anterior vitrectomy, and having all the lenses standby is, and a retina guy possibly around if you have that, if there is a nuclear wall behind.
Just a comment.
That if this case PCR could be converted into a PCC, then you're more confident about placing a single piece in the bag. But if the patient has had a multifocal in the other eye and you're compelled to do it in this eye, you could place a 3-piece multifocal with a good optic capture, and these patients do well.
So just now, Dr. Chitra, a 3-piece multifocal is, I ended up in a situation like this, and I had to actually search for a 3-piece multifocal. It's only the Technis platform that was available, and it had to be got from the distributor in Ambala. So I had to wait for...
From us also, my part. I mean, in the sense that we keep a library of 3-piece multifocals readily available in these situations. And
what all powers is it?
Huh?
All powers you have?
Yeah, we have a library of 3-piece multifocals.
They have a PPC. I think I should call you. Probably call you, send the lenses to me also.
I think they're talking about it.
More seriously, Sheetal, I mean, I think it was hydrodissection, as others pointed out, and it was not hydrodelineation. maybe that's not the only factor. So much discussion happens about classification of posterior polar cataract, etc. But I think any PPC, the approach should be the same. Whether you suspect that it's an open PPC, I mean, anywhere you could land up with a problem. In your particular case, because obviously a posterior capsular rhexis was not possible because it was too large a tear.
Yes.
But now having placed the lens there and the final picture that you showed with a good rhexis overlap, it's I don't think this patient is going to suffer in any way. I mean, you have done adequate anterior vitrectomy.
I recently saw the 3 weeks post-op of this patient. So he's doing pretty well. The lens is exactly the same, but still I think it's a bit of a risk which I took it over there. And as I said, it was the first time I did decide to put MFIOL. I generally put the multipiece in such cases. But as ma'am said that the other eye had the multifocal. So I think I was that time in the double mind what to do with it.
No, as I said, you know, in these situations, I would have definitely gone ahead with a 3-piece multifocal in the bag with an optic capture. But having landed in this situation, having put a lens inside, since there's a lens seems to be well centered and you have a central opening, there's a good rhexis overlap. I think this patient will continue to do well. There's no vitreous strands in the anterior chamber, but obviously this is not something you would, you know, play with and hope that it comes out well. I think with such a large rent, it's always a good idea to go with a 3-piece lens.
Absolutely.
I think the take-home message should be that we should not put the lens in the bag if we don't have the rounding of the PCC, because if it is not rounding, so if it is rounded, then even a larger one you can risk going into and putting it in the bag. But if it is not rounded, the take-home message should not be implanted whatsoever in the bag.
And as Dr. Mahipal sir said, we actually do counsel plus minus anterior vitrectomy and even tell the patient everything and even keep all the lenses ready. But I did not know about this 3-piece multifocal lens. So I think that's again a good idea for such cases where one eye has multifocal and you are always in a doubt what to do if such a thing arises.
3-piece multifocal is a good choice. And I will fully endorse Mahipal. Look at the fellow eye, especially when you have a brown cataract, you do not know whether it's a posterior or a white cataract. Look at the fellow eye and also ask the patient how much time it took for the surgery. Whether it took 10 minutes or 1.5 hours, he will tell you invariably, he says, it took a long time, sir. Yeah, 1 to 1.5 hours. It means that there is a nucleus drop in that patient and PC tear was there and the lens was in the sulcus or iris claw lens or ACIOL, whatever it is. Look at the fellow eye, very, very important.
Thank you, Dr. Sheetal. That was a wonderful video. We go on to our last speaker and a very patient person at that. Dr. Priya, somebody has to become the last. Is a young lady with great skill sets and is practicing in her own Desai Eye Hospital. And she has a tip and learning for us. On to you, Priya.
What about other speakers, Chitra?
What other speakers?
Yeah.
Ramesh Dorairajan's father is in coma. So he wasn't
really?
Huh?
Oh, really?
Yeah.
He's not well.
Not well.
Oh, I didn't know that.
Well, he may not pull through. And Ellen Kumaran had something else.
Ma'am, can you see my screen?
Yes.
Yes, Priya.
Okay. So thank you very much, Chitra ma'am and AIOS-ARC for this platform. I'm the last and I can see that it's 5:22 already. So I'll try to make it as fast as possible. And looking at all these amazing complicated cataracts and how they were managed, I'm going to show a very basic secondary IOL technique, the glued IOL technique. And basically what I'm trying to show out here is that it's not necessary that all the retina surgeons do a cataract surgery, but every cataract surgery should have a basic idea on what they should do when they have certain kind of complicated cataracts. Like if these are the cataracts that are put in front of you, you know that this is not going to be a conventional phaco with the PCIOL in the bag, and you're not just going to get away with it in some 5 or 10 minutes of your expertise surgery. So in this case, what I'm trying to show here is that if you have these kind of surgeries, you should know that, okay, there is a possibility that I might not be able to put my IOL in the bag. I don't have a PC support. So what are the things that should come to my mind? In case if I do go ahead and put an IOL, there will be consequences of an IOL drop and probably the patient will come to me like this. So secondary IOL options, I'll just pause at that. Secondary IOL options, initially we started with an ACIOL, then we went to iris fixated. There are a lot of people who are doing iris claw lens, which have got wonderful results. And then came the glued IOL. the Yamanes technique. I think all these particular techniques have pros and cons, and I've been doing glue dial for quite a bit of time, and I'm having satisfactory results. Being an anterior segment surgeon, there are certain things that I do feel do have setbacks, and those are the things that I'm going to discuss. What is very important in these cases is a very thorough ocular examination. You have to look at the visual acuity and, more importantly, the sclera, because you're going to make flaps. So you should make sure that your sclera is not very thin. Look at your conjunctival mobility. Look at your conjunctiva for fibrosis. Why the cornea examination is very important, because if you have a very dense, thick arcus, you might not see the haptic. Look at your endothelial count and for any other corneal degenerations that you might see. And very importantly, do look for vitreous adhesions, because these are complicated cases that you're going to manage. If you do have any retinal issues like hemorrhages or breaks, then that should be taken care of first before the surgery. So this is a case of primary aphakia. The cataract surgery was done way back. This was a secondary IOL. And if you can see, I'm doing a very wide conjunctival peritomy because I'm doing a scleral tunnel here. I'm going to put the IOL through a scleral tunnel. And after the cauterization was done, an infusion has to be taken. Scleral flaps are made 180 degree apart, 2.5 by 2.5 mm. It is it's very important to use a marker, because I'll tell you why, because 180 degree apart scleral flaps are very important, because that is going to basically rule all the entire steps of the glue dial surgery after that. If your scleral flaps are not 180 degrees, you will end up trying to play with the haptic, try to adjust, and you'll never be sure whether the centration of the IOL is perfect. So once these flaps are made, these are intrascleral tunnels that are made to insert the haptics. And the rule that is followed is on the nasal side of the flap, it should be a superior tunnel, and on the temporal, it should be an inferior tunnel. Once this is done, using an anterior, using an MVR, do an anterior sclerotomy, usually done around 1 to 1.5 mm away from the limbus, but in larger eyes, you might have to go a little bit closer. An anterior vitrectomy can be done from the same ports on both the eyes. Look for those adhesions and try to release those adhesions so your IOL doesn't get fixed into those adhesions when you're trying to externalize the haptics. And as you can see, this is a 23 gauge MST forceps, and it's inserted to the anterior sclerotomy one. And this IOL here is a non-foldable 3-piece IOL. And the leading haptic is exteriorized. And at this point in time, it is very important to keep your assistant very alert with a McPherson forceps to hold the haptic in place while you are trying to exteriorize the trailing haptic. So this is the hand of the assistant who is holding the haptic with the McPherson forceps, and while you exteriorize the trailing haptic. And once both the haptics are out, it is very important to center and then insert the haptics. And while you're inserting the haptics, you will see a movement of the IOL, which will be a very good judge on whether you're clinging it to one side, or you see it drop, or you see it straight or steady. In case if you do see it steady on table, you can probably just go ahead, glue the scleral flaps, and then glue the conjunctiva, and you can probably close your case. And one very important message here is that infusion is very important to maintain. So if you think you don't want to go through the pars plana, you can do it with the AC maintainer at 6 o'clock near the limbus, but infusion is very important so you don't end up with the hypotony post-operatively. Glue dial has as such got a learning curve, but it's a good option for a secondary IOL surgery, and it works well for how it worked for this particular case. So thank you.
Thank you, Priya, for such a thorough detail about glue dial. I have a very simple question to you. What are the tips you would tell to ensure that it's a well-centered IOL? What are the 3 critical points?
I think intraoperatively and postoperatively. Intraoperatively, most important point is that when your leading haptic is going to be exteriorized, your assistant should be ready, because if it keeps on falling every now and then, your pupil might change and you might lose your judgment of the clarity of how centered or how tilted your IOL is. Second is, don't be in a rush to insert the haptics into the tunnels. Make sure you have centered it by holding both the haptics, and only when you're too sure, then you should insert it. And point number 3 is, even once you have inserted, stay put on the table for a few seconds and watch the IOL. You can probably play around a little bit with the iris to see the tilt of the IOL. And if you do feel that, I do feel that it's tilting onto one side, then recenter and then glue. Don't be in a rush to glue the flaps.
Priya, can I ask you one question?
The way of putting it would be to have the needle entries exactly 180 degrees apart, and the distance of entry from the limbus on either side should be equal, and also the entry into the scleral tunnel should be exact and should not be a little off axis tilted. I think these would be some very essential points to have it centered besides all that you said.
Yes, ma'am.
Just stop screen share.
Yes.
Priya, can I ask one question to you?
Yes, sir.
I want to know why the pupil was not dilated in this case.
Sir, basically, we had tried to dilate the pupil, but it was at that, we thought that there were vitreous adhesions, which we did try to remove on table doing that vitrectomy, but the pupil did not dilate further. Honestly, I don't know the reason, sir. It did not dilate further.
If it's a small pupil, because I use a foldable lens, you use a rigid lens in this case.
I do foldable as well, but this was a case.
No problem. In a small pupil, because I want to know exactly where I am going inside and catching the tip of the haptic, and unless I have a larger pupil. So I always put an iris hook. Sometimes I just use 2 iris hooks and just to dilate the pupil in the 0-180 degree in that area, just to know exactly where I'm positioned. Because with the small pupil, you may end up in some trouble. And exactly the centering of the lens also, you may not know if it's a small pupil, where the lens is tilting or something like that. And the Gabor-Sherry tunnel, always stain it with methylene blue. So exactly, you know where exactly to put your haptic. Otherwise, sometimes you lose track of that.
Okay, right, sir.
Anything else to add?
Yeah, basically what you said about centration is something important. 2 more things that Priya actually showed it right in the beginning, but she didn't emphasize is that it should be diagonally opposite to each other. So that is going to give you this thing, and where you are actually making the tunnel is also very important. It shouldn't be far behind in one side and forward in the other side. The other important thing is that you can actually snip the haptics in case you are finding that you want more to go in one side or the other, and there can, because there's some amount of pull that can happen, even kinking at times in the haptic. If you pull it from the middle and it kinks, that also causes a little problem. So these are a couple of the things, and finally you should look at the Purkinje image as to whether it is on the center or not, and that is going to give you a good idea onto whether it is well centered or not, because it usually stays where it is, and that is very important, that on the table it should be centered.
I think nicking off the haptic at the edge is a very important point, sir. I do remember doing that once actually. So yes, thank you.
If you have smaller eyes, then you can do that. And actually for myopic eyes, Amar is proposing to have lenses. So,
go anteriorly, go
anteriorly, or having a larger size of the haptics. But yes, you can nick them off.
Very nice video, yeah, and very well shown. But just to round it off, I am more a votary of the alternative, that is iris clip lens. With a clean cut case like this, it would have been a 5 to 7 minute procedure, and it works equally well. There are of course positives and negatives, but I think like most surgeries, this is another alternative, maybe a faster alternative. And especially, of course, this was a post-operative case that you are doing, so it was a planned secondary implantation. But if you have a problem on the table, you are doing it a topical, then maybe some of these maneuvers are more time consuming. In those cases, I feel that having the other alternative of iris clip lens is much faster. And at least in our hands, I find that it gives equally good results.
Absolutely, sir. And also, I think what amount of manipulation is done, what is the inflammation you were having, and what you decide at that point in time is very important. I do agree to that, sir.
I think Ram, on the iris clip thing, Kiranjit just sent me a video a couple of days ago. He's actually got for segments, he has got for the iris clip now, which he can do, and for colobomas, and this thing he just clips it. So I think
I saw Kiranjit's video. You sent it to me as well. Yeah. Really fantastic concept.
So instead of having to buy morture rings and things like that, or putting them into the capsule, even the absence of support, you can actually decenter the the segment that you have with the color. And
a great addition.
Just to say, sir, but in that I have seen Dr. Kiranjit's video of that. Those are for the iris support, but you cannot really use that and then put the iris claw lenses.
No. He has actually used them as a
For coloboma and for the iris defect.
He had a normal
iris defects.
Yes,
Iris defects is used.
You can clip those to the surrounding iris.
Yeah, sectorial iris defects.
Yes.
Sectorial iris defects.
Yes.
Or only a localized iris defects, he can use that.
The IOL is separate from this segment. The IOL, he had put a posterior chamber IOL, but it was more of a coloboma in the inferior part, so he had clipped it on at the bottom with a segment like you have the Morcher segment or the Morcher ring that you have. Instead of that, he has that to close window defects.
This may be customized depending upon the kind of defect that is there.
I think we've done all the discussions, so I'll come with my concluding remarks. I think it comes very clear to one and all of us. It's been really a fantastic webinar. Thanks to the lovely videos shown by each and every one of you speakers. And of course, a massive contribution by the expert panel. I think the discussions have been really a great learning for each and every one of us. Special thanks to, of course, my dear ARC team who always back me up, and my very sweet little friend Anagha for doing a wonderful job of co-moderating with me. And of course, thanks to the AIOS admin led by Mr. Kripal and his team. And you may not know these webinars running well is all because of the technical support of Mr. Sunil, who does a great job at each and every webinar. Of course, the brainchild goes to Dr. Mahipal, which I think we should always remember and thank him. And thanks again to Sai and Manjula from Numerotech for supporting ARC activities. My very special thanks are due always to Entode, led by Mr. Nikhil, because they have been the only ones to come forward and so energetically sponsor every ARC webinar of ours. And finally, and most importantly, our deep felt thanks to our attendees who give us so much energy by attending it, that we keep trying our best to evolve a very informative webinar each time for all of you. Thank you very much. Thank you.
Thanks a lot, Chitra.
Thank you, ma'am. Great presentations, everyone.
Thank you.
Hi, very nice webinar, exactly on time.
Thank you.
Yeah.
Perfect on time.
Yeah.
Thank you so much.
Contribution of experts.
Hope to see you all in person very soon.
Yes, very soon.
We will hug together.
Soon.
Yes. On time.
One will attend your marriage.